Inertia Health is a premium telehealth platform specializing in hormone optimization and preventative medicine. Are you looking to optimize your health in and out of the gym, improve recovery, sex drive, and quality of life? Have you tried speaking to your health professional about this and have gotten the cold shoulder, stereotyped, or just told as part of getting older? Just go to americahealth.com/table talk, and you can your own lab, or you can take labs that we've had set up for, which are based upon the same labs that I've been doing over the last 15 years. Or you can use their guided optimization. With this, they'll put you in touch with a patient care coordinator, which is actually pretty cool because you get to sit down and speak to somebody that can understand what you're looking for from hormone optimization and the preventative medicine standpoint. After that conversation, they'll determine which labs that you should and which tests you should have done. And then from there, get the labs done. They'll review those labs with you and put you in touch with one of their hormone optimization specialists that can determine which supplementation that you should use over the counter or prescription. americahealth.com/table talk. The discount code is table talk. Today's episode is brought to you by First Detachment. Are you looking for a supplement brand that truly understands hardworking athletes? Look no further than First Detachment. 1D's real world experience is what I would consider, and they consider, battle tested. I have known Justin Harris for pretty close to 2 decades. And if there's anybody that I trust with nutritional and supplement needs, it's Justin Harris. If you guys have followed me and have followed the podcast, you pretty much already know how I feel about the supplement industry. For me to get behind any brand, I have to trust the brand and I have to trust the person both. And I'm pretty sure you guys all know why. When it comes to creating formulas and putting products on the market, and there's nobody that I trust more than Justin Harris. While I love all of their products, I'd suggest that you check out the Field Rations and WTH first. Go to www.firstdetachment.com and use the code TableTalk10 to save 10% off each order. The link is in the description. I want to let you guys know that we just had a limited edition drop on the website last week of new items that sweatshirt, flannel, t-shirts, shorts. Basically, the limited edition items are the items that directly support the Table Talk podcast. So if you go to elitefts.com/limited edition, or actually just the link in the description, you can find the limited edition items that we have now, which there's the one that I like the best is the shit suck good great, which is all emojis. The designs I always like the best, right? They're the ones that don't sell for shit, but they're the ones that I want to wear that I like the best. And there's the cigar one as well. And they're all there on the screen for you guys to be able to see. So if you go to elitefts.com/limited edition, the other thing that directly helps support the podcast that I haven't talked that much about is the Table Talk crew. The Table Talk crew is extra edition episodes that go out once a month. The content of those episodes are AMA related, question related, that come from the Table Talk Discord group, which is also part of being in the crew. When you're in the crew, there's dozens of ebooks that are in there. There's every seminar that we've ever done is put on there. There's courses that are put on there. There's series that are put on there. The original YouTube channel that we had for many years before we migrated to the newer one, all that old content is on there. There's discussion groups for just general training, fitness, life, nutrition, basically everything that you can think of is on. So just go look at what that is, or better than that, just go to the description, click on join the crew. That helps directly support the podcast, which is how we're able to keep this thing rolling.
Today's episode is brought to you by EliteFTS.com. Founded in 1998 with the primary aim to live, learn, and pass on. Please help Elite FTS support this mission by smashing the like button, leaving a comment, sharing with a friend, and thinking of us for your training needs. If you can put it in a gym bag or load weights on it, Elite FTS has it.
What's going on? I'm Dave Tate. We are broadcasting from the middle of the Elite FTS weight room, where the underground still thrives and you're part of the crew. It's time to sit down, keep it real, and cut the bullshit. Welcome to Table Talk. Good. What's up, guys? We're back with another edition of Table Talk. Today, my guest is Dr. Jeremy Girmann. Correct me if I mess any of this up.
Hey, listen, nobody ever gets the last name right. It's Girmann, but the only person to get it right was straight from Germany, like right
Girmann.
off the plane. Girmann.
All right, so Dr. Jeremy Girmann,
Yep.
right? So board certified in physical medicine and rehabilitation.
Yep.
Is that right?
That's right.
And then the practices in, the way that I say your practice is basically a non-surgical orthopedic.
Yeah, that's what I do.
Is that a better way to explain that?
Yeah, it is. You know, I struggle with that sometimes because I'll call it sports medicine, but you know, I take care of 75-year-olds with knee arthritis. Say, hey, I'm not an athlete, and I also take care of, you know, I do musculoskeletal medicine. I don't think everybody knows what that means. So non-surgical orthopedics, I think, best captures it.
Okay. The reason I wanted to have you on is actually there's multiple reasons, so this conversation could go in multiple directions too, where I'm completely open with you discussing any of my medical history that you know of me, right? So that is open. I guess we should probably say anybody that's listening, this is not like medical advice specific to them.
Right.
You know, we need to cover your ass, our asses as much as we possibly can.
Yeah.
You know, so by giving you permission to speak about my cases is not a problem.
Okay.
Right.
Good. Yeah.
Because that's kind of how we met. Is I heard of you from SWIS before, right? And I tweaked, I think the first one was the adductor. I tweaked an adductor.
There were more than one. I forgot.
There's three. There's three. So I tweaked an adductor, and it was worse than my normal tweak was. It was bad. And for those that are listening, I was just doing the power squat machine, felt a little pop in my glute is where I felt it. And then over a period of a couple days, I'm walking around the house, in my underwear, and my wife's like, what did you do to your leg? I'm like, what are you talking about? The whole back of my leg was black and blue. And then it went down, and edema, my calves, and everything swelled up. So my first course of action was Serrano and Kanakin.
Yep.
And Serrano is basically Serrano. Like, what the fuck did you do?
Yeah, of course.
And Kanakin is like, you need to see exactly what's wrong with this.
Right.
Because this looks bad. And it looked really, really bad.
Yeah.
And he said, you know, Dr. Jeremy. I'm like, no. Kind of. I knew the name. Sure. But not really the right last name. Right? So I knew the name. Yeah. And so I went and I looked at the SWIS library. Okay. And then went back to Ken and said, you know, I would like to get in there and see that, because I don't know what this is different, because it bled so much. Yeah. And so then I got a hold of you, and you got me in quick. And then I was sold, because the ultrasound is a game changer in my opinion. Yeah. In a big way. Because I'm looking at this, and, you know, I send the video to Serrano, and he's like, you need surgery. There's no doubt about it. Yeah. Because it was bad. Yeah. And then when you see it, and it's the strange doctor appointment where they're like looking at your balls the first day that you're in there. You know, everything's swollen up and so forth. And you know, scanned it, and it was tore, but it wasn't a full tear. Yeah. And it was, even if it was, I think what you said at the time, even if it was a full tear, it could still lay down and be fine. But the game changer for me was, you know, being from all the orthopedics that I've seen before, sport medicine people I've seen before, you never know for sure. They give you a guess, like, here's what they think it is. Even with my pec tear, you tore your pec. Well, how do you know? Yeah, right. Well, then an MRI, I'm like, how do you really know? Then you got to wait forever. Yeah. I knew that day. Yeah. Right? Not only did I know that day, we had a discussion of how to proceed forward. Yeah. You know, like maybe this might need a surgery, maybe it might not. Right now, it's just so swollen that we need to be able to see. And then fast forward, I believe 1 year exactly to almost the date. Yeah. I did it again, but it wasn't the same musculature where it happened. But that became a different conversation there, where same thing again, like what is going on? But this is where seeing the same person over time can make a difference, because I'm now concerned, like, is something wrong with the prosthetic that's led to this problem where now I've torn 2 muscles in the same way that looked extreme, but not necessarily was.
Right.
Same thing again, just kind of went through the whole process, but it was weird.
Yeah.
And then not long after that, same thing happened to my tricep. And like,
that's right.
Then it was like, okay, what it was, then you started looking deeper into, and we had conversations about training, like, am I doing things that are just totally stupid, lifestyle, all these other type of things. And yes, there were some other issues that were there. There were some supplementation issues that you recommended during that time. And there was a medication that I was on at the time that was creating havoc after the muscle was tore. And this is where, if you don't have that relationship with somebody that knows what they're doing, you miss these things.
Yeah.
So then it was from that going to Serrano and saying, is this med actually still necessary, to be in there?
Okay.
And then it comes out. But where I wanted to go with this is a lot of people don't have access, to what you do. And they tear a muscle, pull a muscle, and their first course of action is to go to their general practitioner.
Yeah.
What could they do better in that case?
Well, in terms of seeking care, it's really, I feel for people, I feel for patients, because the healthcare system is so challenging to navigate, even as a provider. And so for a patient to try to figure all this out, who do I see? Who do I believe? What's the next step? It can really be a tough proposition. So I guess by nature of being on forums like this, like your podcast, people can become aware that, hey, there are physicians like myself, physical medicine and rehab physicians who specialize in this area, in non-surgical musculoskeletal orthopedic care. And there are many, many specialties out there, but finding the person who specializes in the particular problem at hand is absolutely critical, because to your point, you go to your doc who you likely know well, your primary care doc. They're great, but there's such a breadth of knowledge that they're responsible for. They're managing diabetes, and they're managing, the hypertension and all these different conditions. So, they have a fundamental knowledge of the musculoskeletal system, but not an in-depth understanding. And hopefully the primary care physicians are familiar with people like myself who are equipped with the tools and the knowledge to properly address these issues. And also, to your point, you want to try to seek someone who is going to get at the heart of the problem immediately. Because that's really the key. I see so many people who have been treated for months, sometimes years, by good providers, physical therapists, chiropractors, whatever the case might be, massage therapists. But they come in and I say, hey, what did they tell you is wrong? And they say, well, they never said exactly. Well, that's a problem. We have to know which target we're throwing the darts at. And we can use tools like the ultrasound in order to identify day one, the first time I meet people, most often, what is the problem? We can identify it. We can grade it. How severe is the problem? And then we can discuss all of the treatment options available. So in that vein, you also want to go to someone who's going to emphasize education. So often now healthcare, in whatever respect that might be, visits are quick. Education is limited, but that really should be the heart of healthcare, is sitting down with the patient. Hey, here's what you got. Here's what we can do about it. And then when the patient's educated, they can not only treat the immediate problem, but know how to proceed moving forward years into the future.
Actually, now that I'm thinking about it, I've seen you 3 times, and not one time have I walked out with a prescription, but I've walked out with links to several different vitamin K supplements that, to help at that time, which that's a big thing. To me, that's a big tell. And I do wonder though, because I've, over the past, since knowing you, so over the past couple of years, 3 years or whatever it's been, I've reached out to you, and I've tried to refer a handful of people to you. And I don't think one of them, right? And now you follow where I'm going here. I don't think one of them has actually followed through, which kind of blows my mind for one thing, but it makes me wonder if they actually really want to know what the problem is.
That's a good point. It might be that. I think also what comes into play is it's a pain in the butt to, like, whenever I might need to go to the doctor or have something investigated, I don't want to do it. You know, if a hospital is involved, you got to call, you can't get a hold of the right person. They put you through to a million different people, and then you schedule an appointment that's 3 months away, and you go and you feel like you didn't learn them. I mean, it's a pain in the butt to navigate all this stuff.
This is different though, because these are not people that just twisted their ankle. These are people that I've heard, listen, and complain about their issue for months and months and months, and then have gone to, dry needle. They go to their favorite practitioner of whatever modality is being used.
Sure.
And I often wonder with that, and maybe it's just my mindset's a little bit different, where I'm not against any of those modalities, but I want to know what my problem is.
Yeah.
That matters to me.
Yeah, that's a good point. I mean, do people just not want to know? I think that's part of it. I always joke with my patients, and particularly my powerlifting patients. Say there are two groups of people who almost never adhere to the rest that I recommend or respect the time frame to recover. It's my runners and my powerlifters. And so that might be part of it. Hey, I just want to keep rolling. I don't want to hear what I actually got. But if we're able to properly diagnose things, chances are we can get you back much quicker than if otherwise you kind of played around with these different treatments. And
that's a good point. Let's go down that rabbit hole a little bit, because I've been both those people. I mean, I've been the person that when I was competing got hurt and would do anything to be able to get back as fast as I possibly could.
Sure.
And have done some really stupid shit to get back really fast.
Yeah.
But I can say with certainty it probably took some years off of the back end. And I'm okay with that trade-off. But what I've seen a lot from other people is they'll try to rush. And my question back to them now is, okay, if this is a strained muscle, not a mild strain, but grade 2 maybe, right?
Yeah.
And it's going to take 6 to 8 weeks.
Yeah.
And maybe you can squeak out it 2 weeks faster.
Yeah.
Does the 2 weeks really matter? That's my point to them. Like, how much difference is this really going to matter? Because if you had a meet, you probably already moved it.
Yeah.
What if you had to just go out of town and it disrupted your training for 2 weeks? You wouldn't be this upset about it. It's like a game.
Yeah.
And sometimes I think that the checks and balances of the games are not weighed very well. I don't know shit about peptides. We can talk about those a little more in depth because you'll know way more than I do. But sometimes I wonder, like, well, if you're going to take all this shit, say you need to take a bunch of this crap, you pin yourself 3 or 4 times a day, whatever it is, and it gets you ready 4 fucking days sooner than what you would have had. It's 4 days. It's a long weekend, man. Yeah. It's like, is it really worth that? So how fast can they make it? Let's say, this is a very general question, but say it's typically 8 weeks. And if they do all these extra things, I think they think they're going to squeeze it down to 2. But I'm going to guess realistically, the best they could squeeze it down might be 7 or 6.
I think you're right about that. You have to respect the natural healing process. And I'll say a couple of things about that. One is that there are all kinds of philosophies, and that my business is adjacent to John Perillo, who's a good friend of mine. But he always preached that, you can't overtrain only under eat. We always battle. We have these respectful battles. And I said, that's just not right. If a bone fractures, you can eat all the nutrients you want. You can do it. It's not going to heal in 2 days. This stuff takes time. That's the human body. You have to respect that. So it takes a certain amount of time to recover. But to your earlier point, that's the value in assessing these things diagnostically with modalities like the ultrasound, because someone comes in, if they have a tendon problem, I can tell you whether it's just tendinitis, it's tendinosis, which is some degeneration. If so, how bad is it? Is it a tear? Is it a 20% tear? Is it an 80% tear? all of that will govern the recommendations related to return to activity, whether it's 1 week, whether it's 8 weeks. But if you're just guessing, you might end up in a much worse off position.
That's a good point, because if I don't know the difference between the imaging, but let's say they go to another care provider and they just say you tore your tricep. That's a very general word, tear.
Yeah, right.
Right? Because it could be 20%, it could be 10%, it could be 100%, but in the patient's mind, it's 100%.
Yeah.
You know, so if the course of action is surgery, you know, and that's what they're being recommended, all they know is that it is a torn tricep.
Right.
So
yeah, it's a good point. And you know, is it a tendinous tear? Is it a muscular tear? Is it at the musculotendinous junction? I'll have someone, for example, with a distal bicep tendon tear, and if it's less than 50%, hey, we might be able to manage that conservatively and do platelet-rich plasma and different procedures to lay down collagen and try to get it to heal. If it's more in the 80% realm, and particularly if you're a power lifter, you're going to be putting massive load through that tendon, then we might be looking at potential surgery. But we can help to walk through that, as opposed to not knowing and then going through lifts and I don't know if I'm safe. I don't know if I should be doing something else. I don't know. So the diagnostic component of medicine is the most important part. And it's the part that a lot of times I think it's wild to me, but providers underemphasize. They jump straight to, let's try this, let's try that, like you said earlier. But you have to properly identify the problem first.
Go into detail about the difference between an ultrasound and the MRI for those people that don't know that are listening.
Yeah, an ultrasound uses sound waves. And the nice part about it is, unlike a CAT scan or X-ray, there's no radiation. It's in the office. It's readily available. It's cheap. You know, I include it as part of our normal visit. And you can see in real time what the anatomy looks like. It's also a dynamic study. So an MRI, you're laying in a tube, of course, for 40 minutes or so, and it gives you a great image, but you're just laying there. With an ultrasound, if you have shoulder symptoms, I can move your shoulder around while looking at the anatomy to see dynamically how do the structures move, how do they change, and that can imply what's going on with the patient, particularly if they're an athlete, because athletes get weird syndromes where they get pain. Hey, only when I'm doing this, only when I'm at this position in the bench. And we can evaluate that. It's a great diagnostic tool for superficial structures that are under the skin, like tendons, certain joint structures. Now, if you need to look really, really deep, like for example, at the discs and the spine, you have to get an MRI. But an ultrasound is like such a great tool for most of the joints. And in addition to being a great diagnostic tool, it's also invaluable for treatment purposes, because I do ultrasound guided procedures, i.e. injections and different tendon procedures and carpal tunnel procedures. And to be able to see the anatomy while you're doing it, just to give you an idea, if you walk into a primary care physician's office and they give you a shoulder injection, there's probably about a 30% chance they're getting it where it needs to go. With an ultrasound, it's like 100%. You can see exactly where you're putting the medication. So it's a critical tool, and it's so widely accessible, but not that many people are trained in it, which is amazing. It's sort of like anybody who practices musculoskeletal orthopedic medicine but doesn't use ultrasound, it's like a cardiologist not having a stethoscope. I mean, it's critical to what you do to evaluate the structures and the tissue that you treat as a provider. So
I would agree. So the follow-up question would be, why? I mean, throughout the industry, why are sport medicine doctors not embracing this? Why is it, just go here for an MRI, or here's the prescription for the MRI, or what?
That's a great question. Unfortunately, that's changing more now in medical residency programs. It's being integrated as part of the curriculum, ultrasound medicine. And I'm teaching some of these courses where when I was starting out with training, there were no courses. So it's a newer technology. So if a physician's been in practice for more than maybe 10, 15 years, chances are they were never taught or exposed to ultrasound. So that's one function, but as it applies to ultrasound use for the musculoskeletal system, for joints and tendons and things of that nature, it's something. Hang on, can you hold for a second?
Yeah.
Okay, all right, hang on. Sorry, I've been getting this jaw pain, this TMJ jaw pain. You guys can edit that?
Yeah.
Okay, all right, cool. Okay, all right. I need to treat myself, as a matter of fact. I was actually going to do PRP in my own TMJ just hair recently. Just got to kind of let this spasm pass here.
I want to see you stick a needle in your face.
I did one in my hip, but I almost recorded that. All right. All good. I like your questions, Dave. You're good at this. Have you always been a good interviewer?
I've practiced. I've worked a lot at it.
I gotcha.
And it's kind of weird because I'm trying to walk a fine line here where you're not going to trash your own specialty.
Oh, no, it's all good, man. It's all good. It's all good. Okay. We'll pick back up where we left off there. Okay.
All right.
All right. Thanks, guys. Okay. So ultrasound it's not utilized as much because of the fact that it's a newer technology. But also, if you think about it, providers who are interested in musculoskeletal medicine, treating joints and that sort of thing, most of them thought, well, I'll do orthopedics. Well, in orthopedic training, you learn to operate, right? So it's just a function of not only the medical education, but also the newer availability of the technology. But again, now, fortunately, things are changing. More people are adopting this. And I think in the next 10 years, you're going to see that, hey, if you've got a pain, you go to the doctor, that's what you're going to get is an ultrasound.
I think that there's, throughout my time being the meathead that I am, I've seen the gap narrow. Right. Mm-hmm. To where it was, you go to the sport medicine doctor, which is like a joke. Right. But that's like one step up from the athletic trainer or the football team. Mm-hmm. But that was about it. And then from there was this big jump to the orthopedic. Yeah. And that's the scary jump. Yeah. Right. Yeah. Because it's like, oh shit, what's this going to be? Fortunately for me, I was always put in contact with ones that surgery was the last resort. Yeah. So there's all these other things that are in between there. But having this, because surgery is, it can be the outcome. Yeah. Like I'm not on this side where, and this, there are a lot of modality practitioners. So I don't even want to say doctors because they're really not doctors that never think that that's the option. Right. And I think that's complete bullshit as somebody that's had both hips replaced. It 100% is an option, but to have somebody that fills that gap, to honestly and realistically be able to say, you know what, this is now, it is time now. Right. And then you can believe that you're not being sold this just because they need to, pay for their mortgage. Yes, that's right. And in the world of non-operative musculoskeletal care, sports medicine, you have a lot of, it's just like anything. You've got great physicians, you've got not such great physicians, great physical therapists, not so great. Sports medicine physicians, of which I could consider myself. Yeah. Some are equipped with many, many tools and really dive deep. Others, not so much. And even orthopedists, there are some people who took an orthopedic training pathway, but they're non-operative. And so you hope, though, that surgery would be the last resort after all conservative measures have been exhausted. But not always. And you do have to be careful. I just actually spoke with a patient yesterday who called me up and said, hey, look, I just had shoulder surgery. Not going so well. I should have come to you to ask some questions first because I feel like I was just sort of rushed into this. Something was done in the operative period that I wasn't even aware would be done. And so, it can be tenuous sometimes, but certainly there are those cases where it's clear that, hey, surgery is the best option for you and it is going to greatly enhance your quality of life. I want to stay on topic with the ultrasound, and then I definitely want to get into different personalities that you have to work with, especially with that realm, because I do believe there's some people that just want to jump to surgery right away, and there's other people that want to avoid it 100%. So there's you have to deal with both. Yeah. There was a question that came through on our Discord group, which is like a support group for the podcast that people join to help grow the podcast. Okay. And one of the questions that they had, and it was more related to stem cells, so we can branch into that, is if it is stem cells or even prolotherapy or PRP, should it always be ultrasound guided?
Yeah. Pretty much always. Yeah. You want to see exactly where you're treating, and particularly, if it's kind of a diffuse problem, some people use prolotherapy to treat different areas of trigger points and different areas of muscular tension and things like that. But if we're talking about a tendon tear or a very discrete lesion or location, you got to know exactly where you're putting the medication. And to further that point, the way in which the tissue responds during a treatment provides me with a lot of additional information. I tell patients that. So for example, if I'm treating a rotator cuff and it's a rotator cuff with advanced tendinosis, which means it's pretty frayed and degenerated, I tell them that when I'm actually administering the platelet-rich plasma, as an example, into the tendon, it gives me a lot of information about the tissue. So if I have a lot of trouble administering that PRP and I see on the screen that it doesn't flow very easily through the tissue, that's potentially a good sign, because that tendon is largely still intact and the fibers are still adhered together. Whereas if it flows easily and spreads everywhere, that is really frayed and loose. And so that further provides me with information and recommendation related to, okay, here's how slowly you have to take it in the rehab process, or how quickly you can get back to activity.
That's interesting. I wouldn't have thought of that.
Yeah. So the ultrasound is so helpful for diagnostic purposes from beginning to end. And we'll even have people come back serially with pec tears and that sort of thing. Hey, it's a partial tear. Let's bring you back. Let's evaluate it on a weekly basis. Just do a really quick ultrasound scan. That'll let us know when you can jump back into things.
What would be the difference between prolotherapy, stem cells, platelet therapy?
Yeah.
Now, that is a huge topic. I understand that, but from a basic level.
Sure. Yeah, it's a good question. Prolotherapy stands for proliferative therapy. It's intended, the idea is that you're using something in order to stimulate the body's inflammatory response, because as we know, whether it's in the post-workout period or after an injury, there's inflammation. That inflammation is essential for healing, but to an extent. You don't want chronic inflammation. So what you're trying to do with a chronic injury is, with prolotherapy, you're inducing a little bit of inflammation, because the body sort of has a fix it and forget it type of mechanism, where if you have an injured tendon, say tennis elbow, it tries to fix it initially, but then it kind of forgets about it for years. You're like, my elbow gets sore every time I do something. Well, with prolotherapy, you can introduce a solution in order to reinitiate the inflammation, to try to get the body, hey, pay attention to this injury over here, to reinitiate the healing process. And in that case, most prolotherapy utilizes dextrose or sugar water. I mean, it's really not a very elegant procedure, but you take this cheap sugar water and under guidance, you inject it into the injured area. And again, that stimulates some inflammation or provokes some inflammation. Platelet-rich plasma has a similar effect. The difference being that we take patients' blood, we spin it down, we isolate the platelets, and we inject those, because the platelets not only initially induce some inflammation in certain situations, it also then provides all of the necessary growth factors and healing chemicals to further augment the healing response. So it's sort of like you work out, but then you take your protein shake and all your nutrients to further enhance the healing. And then stem cell therapy, and specifically mesenchymal stem cell therapy, is sort of like, I'll use the cliche phrase, like PRP on steroids sort of thing, where now we have cells that are sort of like conductors of an orchestra. Those are the mesenchymal stem cells that instruct the local tissue how to behave and what to do and how to initiate the healing response. So it's just an augmented healing approach that provides all these necessary, not only nutrients, but chemical signals to instruct the tissue to heal, because that's what our body does. When you experience an injury, or if you have an injury, the way in which the healing process takes place is by cells talking to each other. Well, through cellular signals. Well, mesenchymal stem cells do exactly that. They talk to the local tissue, the cells in the tissue, and sort of instruct the tissue to finally heal. So it's a really interesting thing, but I would say that's sort of the order of progression that I tend to take with a lot of people. I start with something really cheap and easy. If you're still having discomfort, maybe let's try platelet-rich plasma, and then maybe mesenchymal stem cell therapy.
How would people be able to know how am I going to ask this? If the stem cell therapy that they're being presented with is quality? And the reason I say this is I've had several people that I've trained with that have come out and either through their, I'm just going to say one of their providers,
Yeah.
not a doctor or provider, but whether they hand me a piece of paper that actually looks like what you would get if you wanted to hire a personal trainer.
Okay.
It's just like this crappy piece of paper.
Yeah.
And like, here's the pricing.
So it's like a flyer.
Yeah. I mean, I can tell right from the jump that this is probably, and that to me, that's like a red flag, dead giveaway. But because that gets thrown around a lot now, the stem cell therapy, and it's, how can somebody navigate that? Right. I think you kind of already answered it, is if there's not something preceding that's a cheaper alternative to work into it, that I think anything for, that's a bigger jump than that, for me, I would see as a red flag.
It's a good point. Yeah. I'm often talking patients off the ledge where they come in saying, I want stem cell therapy. I say, wait a minute, first let's have a discussion about what the likelihood of success is with these other treatments that are much cheaper and easier. And there are a lot of bad actors out there right now. Stem cell therapy is a hot topic, and whenever you get anything that's hot, there are bad actors. And so, I'll get patients in my clinic who, one, for example, just recently came in and said, hey, I went to this clinic up north and they said, I need stem cell therapy for my shoulder. And they were going to take me to the back and do it right then and there. It's $5,000 or whatever the case might be. I said, well, slow down a second. Did they do imaging? No, they didn't do imaging. He said, okay, let's do an ultrasound. And they had a totally retracted rotator cuff where not only was it torn, but it was retracted, centimeters apart. And stem cells, mesenchymal stem cells, wouldn't be able to bridge that gap. So this guy would have wasted $5,000. So you do have to be cautious in terms of so you want to go to someone who's been doing this for a while, someone who's very well educated in it. But in terms of the different types that are available, there are autologous procedures or allografts. Autologous, auto means self. So that's when cells are derived from the patient themselves. Or allograft, allo means other. So it's donated tissue. So sometimes you'll hear about placental tissues being used, umbilical cord tissues and that sort of thing. Now, a lot of this is being governed by the regulatory landscape. A couple of years ago, the FDA was trying to kind of keep up with this and get a handle on where do we go with this new field of medicine, regenerative medicine, all these products that are being developed. Industry was outpacing academia. So to your point, all these companies were coming out with products. Here's my flyer about this product and that product. And they said, slow down. And they instituted some regulations, and those regulations in part set the allografts aside because, again, all these tissue products were being made. Nobody knew exactly what was in them or the quality of them. And so they set those aside and said, well, if there are any active cells in a product, you can't, you really shouldn't use that product if it's donated tissue. And there are nuances to that. This can go deep, but for the most part, a lot of the legitimate procedures are using autologous stem cells derived from the patient. Now, you may hear that over time our stem cell populations decrease, which is true. It's particularly true in long bones like the humerus, the femur, but in more central bones, the sternum, the iliac crest, the populations remain more intact over the years. So I can, for example, harvest stem cells from someone's iliac crest, their hip bone, and get a really good number of mesenchymal stem cells. And then similar to PRP, we spin that down and we extract those cells and we administer them. But there are all kinds of nuances to this in terms of the regulatory landscape. Like, for example, in this country, these procedures have to be done as the same day procedure. So the patient comes in, I take out the cells, spin them down, re-inject. What you can't do, hang on to them for a week and grow them in a lab so that 10 million cells becomes 100 million cells. That's why people are flying overseas, is because overseas you could do that sort of thing. You can take some cells and make a whole lot of cells. In the United States, currently, you can't do that. So there's this is an ever-evolving field, and there's still a lot of misconception, even amongst providers. I mean, my colleagues at the hospital where I cover some days, for example, they don't, stem cells to them, they don't know much about it either. And I've received calls in my clinic where people say, well, is there something with aborted babies here? This concerns me. And that's just a lack of understanding, which I myself can understand. And a lot of that comes from the time when George Bush Sr. was president and, no stem cell research and all that sort of thing. That referred to embryologic stem cells, about which there's controversy. We're talking about something totally different. Mesenchymal stem cells, which are in my body right now, your body. If we didn't have them, we wouldn't live for longer than a day. These are essential. Every time you injure yourself, your own mesenchymal stem cells are involved in the healing process. So there's no ethical questions whatsoever. We can just take them from one area of your body, put them elsewhere. And they're what are called multipotent stem cells. So they can they can turn into different tissue types like bone, cartilage, muscle. Now, that being said, when we use them in the clinic, the science shows that, wait a minute, that's not actually what happens. What occurs is, as I mentioned earlier, they more so talk to the local environment and instruct them how to better heal the tissue. They act like conductors of the orchestra. So we're still learning a lot more about this, but the point I was getting to is that embryologic stem cells, well, those can become an eyeball, a brain cell. Those are only present in utero when we're developing, but these mesenchymal stem cells are present throughout life.
With the regulatory issues, for question A, do you have to be a board certified physician to be able to administer stem cells, or can somebody who is just a chiropractor administer stem cells? So that's the first question.
Well, it's not so much what you're administering, it's whether you're allowed to administer anything. It's, only certain people with certain licenses can do an injection, for example. So a chiropractor would not be able to do an injection, and therefore they could not inject stem cells or anything really.
All right. So my question, the second question, I think you may have just answered that, is when it comes to the regulations, obviously they're going to impact you as a board certified physician hard. Yeah. But if these other people are allowed to do injections, but they're not board certified physicians, then it doesn't really impact them.
Oh,
you see what I'm saying?
Well, yeah, I experienced the same frustration when, for example, you're so well educated in the arena of fitness and how to navigate a gym, but you see so many people are out there doing crazy stuff. Personal trainers who are saying they don't have to document anything. But meanwhile, a physical therapist, they got to document everything they do. They got to have a doctorate degree. They got to pay all this money to go to school. So it's amazing to me that you have a physical therapist who has to go through all this work, who risks being sued because patients, this guy, I'm going to get him. But trainers are out there doing whatever they want, not having, they see it as no liability. Of course, they can be liable, but it's just, and it's the perception of people too. So to your point, it's goofy the way that works.
Well, it's bullshit. I mean, it is. Because I saw a while back, I saw an Instagram post that you made that I felt so bad for you, which was just like the paperwork that you had to fill out for. It was like this. How it was ridiculous.
Yeah, that's one of the reasons why I started a private practice, was because and a self-pay practice at that, because I can spend almost the entirety of the visit educating the patient, and then I make a concise note. Here's what we found. Here's what we're going to do about it. Here's what we discussed. As opposed to these notes that are 20 pages long, where the provider's with you for 5 minutes. Then they have to compile this massive note just to satisfy insurance company criteria for billing and coding. It's a total game. The healthcare system is so backwards and upside down right now. So yeah, it's a hot mess.
Well, one of the things that I've been saying throughout the podcast, throughout this season, if it's, America Health with the hormone performance and all this other stuff, is it's fucked up as this is going to sound, if you want the best care, it's going to be private pay.
Yeah.
It is what it is. And I get why, but that seems to be what I've found.
Yeah. And it's, there are a couple of reasons for that. I guess the biggest reason is that, this is capitalism or consumerism in general, is that, there's going to be competition and enhancement of the quality of the product. Like as a self-pay provider, when I started the clinic, I knew, hey, I got to be good, because if I'm not good, people aren't going to pay their hard-earned money to come see me. So it makes you that much better as a provider. Whereas, if I were in a big hospital institution, I've got 10 minutes with patients, I would like to think that I would behave the same way, but there's not that incentive of, or that feeling of responsibility. Hey, if I don't know the answer, I got to figure it out. I got to go home. I got to crack a book. I got to call some colleagues because this person is depending on me. So it makes you a better provider. And it also allows you to structure your system in a way that best suits the patient. Again, in our clinic, hour-long appointments, extensive education. We talk about nutrition, exercise, even if it's just a visit for knee pain. I just couldn't do that in a hospital environment. I mean, they'd fire me because you're not seeing enough patients. You're spending too much time. So it's a function of the system that when it's governed by these big payers and things, insurance companies, that dilutes the care. But it's also a function of the quality that will be insisted by the patients and provided by the providers when it's a self-pay model.
I think there's a word for it. It's probably leaving my mind right now, but I remember with one of the cardiologists I was seeing years back, shared care. The word shared was in there.
Yeah.
So in other words, it's not just the provider, here's what you do.
Oh, right.
It's like the provider working with the patient together to come up with the best solution. And that's going to be really hard to do in 5 or 10 minutes.
Yeah. I always tell the patient, I feel like my job, my responsibility is to educate you, and then you make the decision what direction to go with your health. And I'll tell the story of when I was in, I think it was residency at the time, and I was shadowing an orthopedic or working with an orthopedic surgeon. And he walks into the room, this young female athlete, and, moves her knee around and says, "Oh, I think you tore your ACL. We'll set up surgery. See you later." I mean, it was probably 30 seconds. And she walked out of the room. I'm still there. She goes, "What's an ACL?" So I had to sit there and explain it to her. So, it's so perverse the way that this incentive system is, and the lack of time that providers spend with patients. And I always tell people that I've got a lot of colleagues who I know are great providers in various health systems, but it doesn't matter how great of a provider you are or you aspire to be. You can only be so good in 5 minutes. You can only be so good in 10 minutes. So unfortunately, the limitations of the system really limit the type of care that's available. I'm trying to figure which direction to go here. I got to stay on this one because it's on the tip of my mind. It's going to make you laugh. And I wouldn't say it was prolotherapy, but I'm going back 30 years, maybe even longer than that. I'm going to date myself here, and for some people this worked, and I'm going to ask why. But for some people this worked well. Other people it didn't work well. I'm not recommending it because for the people it didn't work well, it was usually due to an abscess because it's basically just it's self-administered saline shots is what it was. Okay. And actually this came from this is typical meathead. Somebody read a Penthouse magazine, and in the Penthouse magazine there was one of them little blurbs, just like a paragraph about how physicians were injecting saline into the knee like it was a wash. And then it was having real positive effect. So some idiot that knew another idiot that knew another idiot figured that they would just have a nurse get them the saline bags from the hospital, and then anytime we tweak a pack, we just just whack 3 cc. Actually be 9 cc's total, just boom, 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 just whack through there. And I had it done a lot, right? So, and after a while, now the ones that the reason I say it's not good, and there's a lot of other reasons why this is not good, by the way, is a couple people did get abscesses, right? Because it's in a dirty ass gym, and now you're dealing with a way bigger issue than a strain pack or whatever it was. But after a while, I started thinking it's just saline, right? So is it the needle tearing through the muscle that's initiating the inflammation, or is it the saline initiating the inflammation? Some idiots, by the way, tried to use peroxide, and that was not. I did not partake in that. Well, I did on my quad once, and that just a little bit, and I never ever. I bet that hurt.
It did. It hurt like a bitch. I mean, but the saline wasn't bad. But the reason I'm saying this is there's still people now that I know will venture down that route, and they actually call that prolotherapy, which is it's really kind of not, because it's not guided. It's a different type of thing. But I always wonder if that's the case and they're finding success with it, could they find the same success with just dry needling?
That's a great question, Dave. to comment on the saline injections, that's something I've actually explored. And I think what might be happening is that when you have experienced an injury or a painful process, that pain is related to different inflammatory chemicals, interleukins, cytokines that are present in the tissue. And I think when you infiltrate the area with saline, which is an innocuous substance, so it really would be net neutral in the tissue. It wouldn't induce inflammation, wouldn't really help to directly resolve inflammation. But I think what might be occurring is you get like what I call a chemical washout. So you sort of dilute and wash out some of these inflammatory molecules. So I'll use this actually. I take care of a number of professional athletes, and sometimes when they're in season, if they have an injury or a chronic tendon problem, well, we can't do PRP because that's going to make you really sore, and you got a game in a couple of days. So, and we don't want to do cortisone. It's just going to weaken the tissue over time. So we might do this washout where we infiltrate the area with saline. It seems to really work. Now, that being said, I always do it guided. So I know exactly where I'm placing it, because what you don't want to do, for example, is place it right into a tendon. I'll place it around a tendon. Mm-hmm. You don't want to disrupt the healthy tissue, which is the risk you run. So it won't have the same effect as prolotherapy, but it might have some value for more acute injuries. Prolotherapy, on the other hand, is more so to address chronic problems, because again, you're talking about cases in which you tweak your pec. Yeah, I've got this thing that just happened. There's inflammation. A lot of times prolotherapy is used when I've got this old tennis elbow. It just never healed right. Let's try to get it to heal now. So a little bit of a different scenario there. It's interesting, though, the way people come about things. I'll tell you, I learn more from people who hang out in gyms than probably I learn a lot in medical school.
Oh, yeah.
Because there's a lot of self-experimentation.
Oh, 100%. Yeah. One thing I was going to say about the ultrasound guided injections is with my hip, there were cortisone injections, and I did by a year with one cortisone injection. And then with the other hip, it wasn't ultrasound guided. Okay. Right. So I knew as soon as I got off of the table, because there's also the lidocaine. Yeah. And so normally, like immediately afterwards, the pain should be gone just because of the lidocaine. Yeah. I knew as soon as I got up, it's not good. But my takeaway from that was, and this may have changed now, I then could not get the replacement for something like 4 to 6 months. Right. Because cortisone was then in that area and in that system. Right. Which it makes you, it's like shit.
Oh yeah, especially if it doesn't help, right?
Especially if it doesn't help, because now it's 4 to 6 months of just being screwed. Right. Where it would be, my advice to anybody is, if cortisone's the last, that's the last leg. Yeah. Right. So that's, in my opinion, should only be done if surgery is on the way and you're just trying to buy time because you have a vacation or some shit coming up. Yeah. And but if it's not guided, man,
Well, it's a great point. And as it relates to cortisone specifically, there are cases in which I agree with you. It's one of the reasons I set up the clinic, is because I wanted to facilitate treatments that I would want to get, things that are restorative, regenerative, platelets, plasma, things like that. They're going to enhance the longevity of tissue, not take it the other way. That being said, there are times that cortisone can be more appropriate than others, but you have to be very discriminate, and a lot of people aren't. So, for example, there are some tissues that respond much more favorably. In other words, they don't experience much of a deleterious effect from it, where others can be substantially harmed. If you put it around the wrong tendon, you can really weaken it. If you put it into the wrong joint, it can really compromise that joint, whereas others tolerate it much better. For example, sometimes if people have like a mild tennis elbow, and I do an ultrasound, I see the tissue is pretty well intact, but it's really painful. They're mid-season in their sport. I said, let's put a very low dose of a cousin of cortisone around this tendon, calm down the inflammation, and your body will take over from there. It might go away. Whereas if I see a tendon that's really frayed and beat up, I say, ooh, wait, this is too vulnerable, and it might make it even more vulnerable. Further, there are certain tendons like the tendons that are in the forearm. You can kind of think of them as like strings on a puppet. They're more positional. They move the fingers in space. They're not very elastic like these big bands you have over here. Whereas things that would be more elastic tendons would be an Achilles tendon, a patellar tendon. They store a lot of energy. They're very bouncy. I never put steroid around those because they are more vulnerable to the steroid, and you don't want to rupture an Achilles tendon. So you have to choose correctly. And also, as it applies to certain joints, there's now this thought that one of the reasons arthritis and other conditions tends to progress is because we used to think it was just a wear and tear problem. It's like you bend a coat hanger one too many times and it pops. Well, it turns out that a large part of the equation here, it's like chemical warfare within the joint. So if you get a problem, if you get an injury, a little bit of arthritis, you now have this release of inflammatory molecules, enzymes called matrix metalloproteinases, which you can think of as like little Pac-Men that float around and chew up collagen. There's like this unhealthy soup within that joint fluid now. And that over time further degrades the tissue. So it becomes this vicious cycle. Well, we can counter that with things like platelet-rich plasma and stem cell therapy. But even there's some thought that, well, if I use a very low dose of anti-inflammatory and I knock out some of these inflammatory chemicals, dousing the flames might be a better option than allowing the fire to rage. So again, it has to be chosen very cautiously and discriminately. But a lot of times what's happening is it doesn't matter where in the body you're talking. People say, let's slug it with a high dose of cortisone. And that's not the right option. So you have to talk through all this with the patient, the risk benefits. Here's why I'm recommending this for that area and not for this area. So there's usually more to the story with this stuff.
Oh, there always is. It's the two areas to go there is, in the past, I've dealt with bad plantar fasciitis, and I'm all about cortisone for that, right? Because that makes a big difference. But it's your foot, right? And you can't walk, and that definitely helped. But that's not the end of the story with that either. There's a reason why it's there.
Yeah, that's a good point.
And just going into arches is a shitty solution to it. Yeah. So I can go in a long tirade
sticking
about
you in a boot or something like that.
Yeah, and well, they did, right? Yeah. Then it takes a while. We got people that have these issues, right? Yeah. So it took me a while to realize now my arch is now being supported. Yeah. So my foot's now weaker. Yeah. And then it took me a while to learn I need to strengthen the foot. Yeah. And then to go from insoles when they were tired. Yeah. When my feet weren't tired, bare feet. And then foot drills. Do you see this a lot, by the way, just the plantar fasciitis?
Oh, I mean, every week.
All right. So you walk us through what typical mistakes people make with that. Because I think it's more common than people say. They just don't do anything about it.
Well, this comes back to the very beginning of our conversation, which is first I make sure that people have received the right diagnosis, because I would say 40% of the time in the case of plantar fasciitis, it's not actually plantar fasciitis. They come in, hey, I've been to physical therapy. I went to podiatry, the foot doctor. They gave me some cortisone injections, didn't really seem to help, or maybe help for a little bit, all kinds of stretches, insoles, etc. And then we dive into things. We say, oh, this is a nerve problem. There are, for example, several other things that can masquerade as plantar fasciitis. You can have a calcaneal stress fracture. You can have something called Baxter's neuropathy, which is something I diagnose quite often because I see a lot of runners. They get it a lot. And the bottom line there is that there's a little nerve that's a branch of the tibial nerve. And it's called Baxter's nerve, or the first branch of the lateral plantar nerve. And it's a very small nerve that goes right to that area where the plantar fascia is, but it can get impinged. It can get impinged along several points, and it can mimic plantar fascia pain. So I'll have people who have received all kinds of treatments for plantar fasciitis, and then they come in, we treat this nerve, pain's gone. So again, I can put the ultrasound on. I can say, hey, your plantar fascia looks fine. This nerve, it looks like it might have an issue. Now, that being said, if they actually do have plantar fasciitis, or fasciosis is like the chronic form of it, a lot of times I'll let the appearance of it on ultrasound govern the treatment. So if it doesn't look that bad, we can start with certain biomechanical things, certain stretches, etc. Sometimes wearing what's called a Strasbourg sock, or a sock at night that keeps your foot dorsiflexed, keeps that stretched out. That can help, because what happens is in the morning or at night, we sleep and our feet point down because the sheets are keeping them pointed down. So that plantar fascia tightens up. And as soon as you stand up in the morning, when you put all your weight on the foot, you create micro tears in that plantar fascia. So at night, if you wear these socks, that basically is it's got a strap from the toe to the tibia. It looks ridiculous. But if you wear that at night, it keeps the plantar fascia stretched out so you don't have that problem in the morning and that recurrent tearing. So that can be helpful for mild cases. But if it's more advanced, as we identify in ultrasound, then I'll start moving to, well, let's consider platelet-rich plasma. There's something called a fasciotomy or tenotomy that I can do where I use a little device under ultrasound and I clean up the fascia, which is basically what they do surgically, but I can do it through a tiny little numb poke area. So there are all kinds of different treatments. But to your point, if it ain't working, you probably don't want to keep doing it. And it drives me crazy, Dave. I made a video about this. These boots. I don't get the boots. I mean, people, even a lot of foot specialists, people come in with a foot problem. They said, first treatment is wear a boot. Doesn't work after 6 weeks, keep wearing the boot. I don't get the boot because then people come in with knee pain, hip pain. Now, if you got a fracture, if you got these different things, some cases it's certainly appropriate. But I can't tell you the number of people who come in, to this point, what have you had done? I wore a boot for 10 weeks. Did it help? Didn't help. So get it evaluated earlier so you don't have to be trucking around on this boot for a couple months and not get any relief from it.
I know a couple people that, it's insoles and then boot, basically boot, it's, been told high heeled, high ankle support with insoles. Meanwhile, their knees are fucked up, their back's fucked up. It's like, dude, it's because you don't, but they don't listen. And it is what it is. So it's now I'm sure with your runners, they're not going to stop running.
No.
So there's that.
It's challenging.
That's moving into the direction of the different types of patients that you're going to have come in. So there's obviously rest helps. Right. And there's going to be those people that will a little bit, and there's going to be I think there's people I talk to, there's people that just seem that they just want surgery. Right. That's one group of people. And then there's another group of people that just want an excuse that they can use for forever.
Right.
Back hurt, shoulder hurts, that's whatever. It's just always
they identify with it.
They do. And then there's another one that the compliant one, which is probably the smallest portion. And then I'm forgetting the other one, but when you're dealing with, which ones do you deal with the most? Because you're in different places. So you're in a hospital, it's in your work with veterans too as well, right?
So I cover a couple of days at a VA hospital, which is interesting because it's the total opposite of my private practice. I started working there fresh out of residency because I could see that they needed the help. Every veteran's got joint pain, right? And they didn't have enough staffing to address it. And at the time, I was also building my private practice where the patient population skews younger, healthy, active, proactive. So the contrast is really, really interesting. The veterans definitely are in that non-compliant category, most of them. And that can be particularly challenging. In my private practice, it's people are very compliant, again, because they're paying their hard-earned money. They want to get results. But because we see so many athletes, they don't want to stop. So I see all of those groups. Now, for those who have trouble backing down from the sport that is their passion, fortunately, in the old days, we used to say, well, you got a bed rest for weeks. Okay, we don't want you doing anything for weeks. Now, fortunately, the new science shows that movement is good. Movement is like lotion. It keeps things going. It's like the cement truck that keeps spinning. And so if I can convince some of these athletes to just back it down, they can continue with certain activities, exercises, but we just have to modify things to facilitate tissue healing, not further tissue damage. Then that's enough to usually satiate them to say, okay, I'm cool with that as long as I can get in the gym and do something and then ramp up. So while I do struggle with it, and it can be challenging, that's part of why we do what we do. The company called our company Inertia, the initial tagline was helping bodies in motion stay in motion. Now, since then, we've integrated other disciplines and specialties, and we've kind of grown. But that was at the core. I love to do certain things. I want to keep doing them. And unfortunately, a lot of times when people go to providers, they say, it hurts when you do that. Well, just stop doing that. People aren't going to accept that. We got to be realistic. If people want to keep doing it, hey, I know you're going to keep doing it. Let's talk about the best way to facilitate that. So that's what we try to specialize in.
When use myself as an example because I've been through it. So the time that I saw you, actually it's each time, but there's more in that conversation than just what the issue is, right? So a couple times as the adductor, one time as the tricep, and all times we've talked about my shoulder, which is a mess. So it's a locked up mess. But that's a can that we just keep kicking down the road because part of the questioning that you have is, is it livable? Is it tolerable?
Yeah.
Are you good where it is now? It's like, okay, good. Okay, we'll worry about this later. Yeah. Right. So, that's a lot of people wouldn't do that, because they would see this as an opportunity to be able to go, in that one direction. But then there's also those other questions of, I think it might even be part of the intake that I fill out, it's the sleep, the supplementation and all these other things. And it's a more holistic approach. Yeah. So where I want to go with this is when those holistic factors, how many times do you see those more holistic factors off kilter with the patients that come in?
Meaning how often are they not addressing them?
Yeah, just things like sleep, stress, diet, supplementation, things that I think could potentially be why they're there in the first place.
Because of the setting we're in. Yeah. We'll talk about the meatheads.
Yes, yes.
And really it's fitness, an interest in fitness is what led me to medicine. So we, have a lot of mutual friends because of that. Yeah. And so this is kind of my world too. If they've got a problem, their answer is train harder or, supplement more or whatever the case might be. When I say, wait, let's go back to the basics. Maybe let's look at your sleep a little bit. Let's look. So very often people aren't addressing the foundational principles. I think there are reasons for that. It can be hard at times, but also we take for granted what an impact a good night's rest can have. I mean, that's the thing that I most often fall short in. I'm pretty good with exercise, diet, sleep, not so good. There's just not enough hours in the day as far as I'm concerned. So very, very often. And stress is like they say hypertension is the silent killer. Stress is the silent killer, which leads to hypertension. I mean, that's something that isn't being addressed these days. And with the fast-paced world, the social media world, we're going to say what's up to the people on Instagram and YouTube and all that sort of thing. But it just becomes maddening, and you throw that in with a hectic lifestyle and then overtraining a lot of times because that's where people get their release. So they go crazy in the gym, and then you throw that on top. The body's just overstressed. So you got to respect that downtime, that rest, that recovery. You got to address all the fundamentals.
How responsive are the patients when you bring those things up?
They're responsive because I think it's one of these things where a lot of the concepts they know, but I'll iterate on the subject and I'll teach them some things maybe they didn't know. But then they're also struck with the thought that, oh man, if this guy's telling me, then it must really be meaningful, because it's the same reason why some of my colleagues, they'll say, well, I don't know why you spend time talking nutrition with people. You can pay a dietitian to do that and see another patient make more money. I say, because I'd be doing them a disservice if I didn't talk with them about these things. And the fact it's coming from me emphasizes the importance I place upon it. And so I want them to know that. I want them to know how important I think these things are. So people are very receptive when you open the discussion because they realize, oh, this all goes together. It's not one intervention. They realize that I'm not someone who writes a script, sends them out the door, does one procedure, see you later. Let's consider all the things that are contributing here, because as I tell individuals, if I do my job well, I shouldn't really see it again, or at least not that often. I've got a little bit of a problem with the business models where, they're just like, I need to see you 3 times a week for the rest of your life sort of deal, Yeah. So it's something we try to do differently.
With the meatheads that you see come in, there's, I'm wondering, this makes me wonder, are there, I don't want to say correlations, so let's just say spurious correlations to make it more general, that you find, because I'm sure most of them are coming in because of, if they're older, it's either arthritis or they pulled a muscle or torn a muscle or something like that. Are there these spurious outside, things that you've noticed just from seeing so many people that's like, oh, this is interesting. It seems like everybody that tears something also always is taking way more fucking hormones than what they should, or or they're all on this high fat diet, or they're all on, anything that just seems to be spuriously tied.
Yeah, it's a good question. And a couple things come to mind. One is that, a lot of people are well hydrated, but not hydrated enough, or at least at the right time. They'll train at a time when they're either coming out of work, and they'll start, pounding the fluids like during the workout, but you need to do it hours before. So particularly when I've been seeing a lot of fascial tears, I diagnose a lot of fascial tears, which I think they're underdiagnosed. Those happen a lot of times when people are underhydrated. So a lack of proper hydration from a substance standpoint, that's another thing. I learned things from people in the gym. There are a lot of people who are much more learned than I at this stuff. So I'm learning from them. But, and it's a weird thing to me, because a lot of people I am proud that people feel comfortable telling us what they're up to. I need to know if we're going to be able to treat you properly. So you hear things and you learn things, whereas a lot of doctors, they shame people. I don't care what people do. It's their life. But one thing I've noticed is trenbolone, man, you major tears. Some of the worst tears I've ever seen were when people were taking trenbolone. It's just, it's a hardcore, anabolic. And there's something about, I think it's not only the way in which the muscle grows relative to the connective tissue, but also the way in which the connective tissue is changed in the metabolism of the connective tissue. So I've been kind of looking into that a little bit, but some of when people come in, particularly certain athletes with a weird tear, like, for example, I had someone who was a pro bodybuilder who tore his flexor pollicis longus. It was the flexor of the big toe muscle. It like sits basically under the calf. He's like, I can't flex my toe down. I don't know what happened just a couple of days ago. I said, what in the world? That's kind of weird. He said, I was getting on my shoe one day. I kind of moved my foot funny, but we did an ultrasound and I'm like, you tore this muscle. I said, I've never seen that before. I said, were you taking trenbolone? He's like, yeah. So, that's one thing I noticed. And another big thing is that people, and this probably gets at what you spend a lot of time thinking about is training protocols. I mean, there are different type of athletes that have to be mindful of training a certain way, because the way in which they usually train sets them up for certain types of unique injuries. And we could get into that if you want, but it has to do with the way tendons form and the way tendon health is maintained. And certain type of athletes, if they don't every once in a while do certain exercises, they're more likely to tear at certain locations. So it's training, it's supplementation, it's nutrition, hydration, it's all that stuff. And I made a video, Dave, that, the way in which to avoid injury is don't record yourself, because I'm telling you, the number of patients who come in and say, oh, I tore this muscle. How'd you do that? They say, oh, let me show you. They pull out their phone. And it cracks me up. I think the reason is because even though you're trying to be fully engaged in your lift, there's a couple of those brain cells that know you're being recorded. You're not 100% dialed in, because there's a little part of your brain that's focused on something, or at least is aware of it. That's enough to make something pop. So
in short, if you're taking trend and you're not hydrated and you're training for Instagram, you're probably going to tear something.
You're in trouble.
Yeah, I do want to go down the road of some of what you're talking about with the training there, because it piques my interest.
Yeah.
So I assume part of what you're saying there is just a basic lack of some type of periodization, but are you alluding to other movements that they should be putting into the program at certain times that they're not?
Well, I'd be interested to get your opinion on this. And I'll briefly comment on muscle physiology. When we think about tendons particularly, because a lot of tears involve, you've got your intramuscular tears, but a lot of tendons involve either the musculotendinous junction, the tendon itself, or the tendon from the bone. And so a lot of people have a misconception of what of the anatomy of tendons. So we think muscle here, tendon, and then bone. It's like a sharp transition. Really, it's a gradual transition. And so if we consider the anatomy for a minute and the physiology, if we think of a bicep muscle, the majority of the load or the tension within that muscle while it's working is actually transferred laterally. So let me further explain that. We remember the actin and myosin. And if the muscle longitudinally goes from shoulder to elbow, we think all the tension is running this way as those actin and myosin filaments crawl across each other. But that's sort of like playing tug of war. I'm pulling the rope, and every time I pull but then let go, I risk losing some of that rope, of the tension. It's not a very efficient way to maintain maximal tension. So actually what happens is the majority of the tension is displaced laterally out to the side. So if you can picture it this way, if we're in a game of rope, tug of rope, then I'm in trouble against you. But if I've got like a pole behind me, and we were talking about Steve Big, shout out to Steve Big here.
Steve Big behind you.
If he's behind here, every time I pull and get some slack, he pulls up on that slack. Now we're going to win. Okay. So that's what other proteins in the muscle called titin and a protein that musculodystrophy affects. That's what these proteins are involved with. But then the force gets transferred to connective tissue within the muscle. So it starts within the muscle cells all the way up at that level. And then these connective tissue fibers, as they dive down towards the joint, they coalesce, they come together, they form what we know as the tendon. So it starts much higher up in the muscle. There's a large surface area within the muscle for it to kind of evenly distribute that load. And then it comes down, the tendon fibers, the collagen fibers become thicker and denser, and they attach to the bone. Okay, well, there are certain types of exercise. Tendons can become stronger two ways: either increase the density of the collagen or the cross-linking of the collagen. Now, the cross-linking is enhanced by a couple of things: either quick load, like a power sport or a quick change in direction, that enhances the cross-linking, which in effect enhances the stiffness of the tendon. So you know that a lot of things that powerlifters do, they want kind of a stiff structure so they can support that load.
But elaborate that on just a little bit, because you're talking about, a stretch reflex, or some people will hear that and they'll think that you're talking about like a box squat standing up fast. That dynamic aspect of, but that's not what we're talking about here. We're talking more about that reactive.
It's more about that bounce.
Yes.
It's more about something where, if you picture the tendon as being a rubber band, if you go down, you bounce back up.
Yes.
Or you're, a football player and you're cutting from side to side. So that sort of activity, it enhances the cross links and the stiffness of the tendon. Now, that can be potentially problematic, because if you've got this very compliant muscle tissue that is sitting adjacent to a very stiff tendon, that's a vulnerable spot. That junction point, the musculotendinous junction, is very vulnerable. And so that can be a common place where people tear. Now, one of the things that they found helps to break some of those cross links or keep a nice balance of forming cross links and then dissolving some of them, essentially, is doing slow eccentric movements or negative movements. The reason for that is because when you do a fast movement and that tendon is under a quick load, it's sort of like, when if you slowly lower yourself into a pool, no pain and no issue. If you belly flop, you go fast, it hurts because the water molecules, when you go slowly, they can adjust to the load. But if you go quickly, they all move together and they form more of this resistance. So when you move slowly in a motion, those fibers kind of move independently and they can break some of the cross links between. Whereas if you move quickly, they kind of all move together and those cross links stay, those bridges stay intact. So the point there is that if you're someone who does a lot of quick, bouncy, explosive movements, that you need to every once in a while integrate slow, particularly eccentric movements to break some of those cross links. Because if not, you're going to be someone who's in this category of very stiff, lots of cross links, and that makes you vulnerable to injury at that musculotendinous junction. Does that make sense?
It does, but where my question would be, if you're taking somebody, if we're looking at extremes here, and we're taking a football player as an example that doesn't do any strength training, but just does all speed, agility, quickness, all bounding, plyometric type of work.
Yeah.
Then to them, just weight training alone would be inducing a slow eccentric compared to what they're normally used to.
Yeah, that's right.
So I guess what I'm asking is what is the parameters of what defines the slow eccentric?
Well, that's not particularly well defined. Yeah, that's the tough part. But generally, I'll recommend that whatever your sport is, like if you're a runner, runners very commonly have hamstring tendon issues. So what I'll recommend is that they train those tendons. So if it's a day they're not running, they might do slow, stiff leg deadlifts or something for several sets in order to get that slow eccentric movement. Now that touches on another topic, which is an interesting one, particularly as it applies to weightlifting. When you're exercising, when you're working out, when you're lifting weights, the tendon cells or tenocytes remain responsive to the stimuli for only about 10 minutes or so, and then they just kind of shut off. Whereas the muscle cell remains responsive pretty much the whole time. There's a lot going on within those muscle cells where they're perceiving and responding to the stimuli. So the issue there is that if you have a long workout and a particularly aggressive workout, your muscle is going to respond to that. Your tendon only responded for about 10 minutes or so. So your muscle can essentially be out-trained or overtrained relative to the tendon. So there have been some studies that indicate that if you've got a tendon issue, or if you want to be proactive and not have a tendon issue, you can do tendon training, which would be to split up your training and to train in a segment earlier in the day and later in the day so that your tendons get stimulated twice instead of just once. Now, they found there's a refractory period of about 6 hours in which tendon cells don't respond after stimuli. So you start working out for 10 minutes, they're responsive, and then they become unresponsive for about 6 hours. So then 6 hours later, you could train again, and you could get another bout of tendon stimuli, which can further enhance tendon health. Now, the interesting thing is that they found the load doesn't really matter. So you don't have to go heavy both times. You can go light both times. You can do a lot of reps. You can do a few reps. But 10 minutes is the bottom line. As long as you're training for 10 minutes, you're going to get activation and stimuli of those tendon cells. So if you've got a problem, training them a couple of times a day might be the best option.
So what you're talking about let's just call this tendon threshold training.
Yeah.
Is if it is an RDL or a dumbbell RDL, it's not going to make any difference if I'm using 15 pounds or 80 pounds, to me, it would make a difference to use the 15.
Sure.
Because if it's just for that purpose, then I can lower it slower.
And you can preserve maybe the muscle for your more intense workout or whatever the case might be. Yeah, it's kind of it's a concept I don't see many people utilizing, which is tendon training. So where you train multiple times a day for these short bouts just to enhance the health of the tissue. But I think that's another reason why I see a lot of tendon problems with powerlifters, because their muscles are so well trained, but the tendon just has not had the proper stimuli to adapt to the load, and it needs to be trained more frequently. Although it can be a very low volume, that second period.
Yeah, that's interesting though. What I've heard is that some of the reasons, and I think there's always multiple reasons for everything, right? There's not anything's just one reason.
Sure.
But some of the reason for the injuries that people have is because they lose strength and end ranges of motion.
Yeah.
So if they're doing a dumbbell press, which I wouldn't use as an example because of gravity, but say a standing cable press, they'll go from here to here, but they don't ever let it go a little bit deeper than normal and actually do strength work in that range.
Yeah.
Or even a little bit of even PNF work in that range, just to try to get more range of motion.
Yeah.
And loaded stretching in that range, where I've seen value in that, because it doesn't have to be all the time. It can be the last exercise of the set.
Right.
Where, the thing that you're talking about is, let's assume it doesn't do shit, right? It's very easy to throw one thing in,
Yeah.
at the beginning of a session as part of your warm up,
Yep.
to be able to hit most common areas of injury,
Yeah.
for that sport.
Yeah, I think that's great stuff. And they've definitely shown that if you are not used to training at a certain range of motion, you're more vulnerable to injury, right? And a lot of that's related to Golgi tendon organs. The brain kind of shuts off muscles at a particular range if it knows that you're not strong enough to support the structures in that area. And so when you do that, I think a lot of things are happening. You're stretching out some of the connective tissue that better accommodates to that position. So to your point, there is a lot going on there. And being thoughtful about the way you structure things, not only from a muscle standpoint, but also a connective tissue standpoint, is incredibly important.
I think it's hugely important, especially if you're speaking of powerlifting. Right. It's a sport that at its basic level, you're trying to take 3 compound movements and do them through the shortest range you possibly can.
Yeah.
So you're trying to find a shorter range to do it, which means in the process of doing that, you're actually not working these joints through full ranges of motion.
Right.
In the bodybuilding sphere, you might start out doing that till you get super jacked and you're 260 pounds and have 21-inch biceps.
And you can only move so far.
Then you can only move so far.
Yeah.
So then and these are, I would say, I look at these as preventative, type of things. And it's great that we're discussing it, because these are the things I'm the most interested in, because I don't want to be any more fucked up. I'm looking at things from probably a later perspective than like an earlier one.
Yeah.
And earlier in my career, I was doing things that were preventative for what I knew at the time.
Okay.
I wasn't a complete fucking idiot. I just did a lot of stupid things, but I wasn't that. But for me, the odd thing was it was knees and backs.
Yeah.
Like that's what I was seeing. I was seeing knees, backs, pecs, knees, backs, pecs.
Okay.
And then I strained a pec like in high school. Then I'm like, I guess I'm fucked there.
Yeah, right.
But then it was knees and backs, knees and backs, knees and backs. Never had problems there.
Okay.
The hip. I never thought about the hips.
Yeah.
Now I think the lifters, at least the power lifters of today, can benefit from the ones that came before.
Right.
If anything, just to be able to say, what are the most common injuries?
Yeah.
And then what are some things that we can do to mitigate those?
Yeah.
And that's just, to me, intelligent training.
Well, it's essential, right? And aside from the training, there are some other strategies that I'll sometimes use for people. We talked about the need to be extremely well hydrated. So, I mean, tendons, people think of bones as well. It's just like a piece of wood, or, tendons is just a rope, but it's a very dynamic structure. And tendons, for example, they're 60% water. So they have what's called viscoelastic properties. In other words, they behave not only like solids, but also like fluids. The physics or mechanics of it are such that that water aqueous component is very important. So the hydration is critical, but also there's a lot now you're hearing about taking collagen supplements and that sort of thing, which I am a big fan of based on some of the literature and even the theoretical mechanisms here. But I've noticed people kind of take them just whenever with their morning coffee, but really there's been some evidence that you should take some of these supplements that are intended to enhance the health of tissue, tendon tissue, like 30 to 60 minutes before you work out. So you want those nutrients to be present for those tendon cells when they're activated during that first 10 minutes of the activity, in order to then lay down more collagen and really ramp up collagen production over the next 24 hours. So pre-workout, I'll have people take 15 or so grams of hydrolyzed collagen, some vitamin C, whether they eat an orange or take 500 milligrams of vitamin C pill. Those are some of the things I have people do. Copper is also important. Most people get enough copper in their diet, particularly if they eat meat. So from a nutritional standpoint, there's a lot people can do too. And I often think people overlook that as well.
Oh, they do. And it's the collagen I throw in my oatmeal in the morning. So I'm one of those guys there.
Yep.
So I can change that. The seed, I definitely do.
Yep.
The as far as the hydration, I use the Element, which is it's right there. I mean, it's potassium, sodium, and I don't use it the way people think. Like the chocolate sounds kind of gross, right? But I put it in my oatmeal, like half of it, and then it's there. Then the other half I'll have while I'm drinking. Yeah. Vitamin K, I've been a proponent of since you suggested it.
Oh yeah.
Just because of the go into that, because I don't even know why the hell I do it anymore. It's just was suggested.
Yeah, vitamin K2.
K2, I'm sorry, yes.
Yeah, there are, I think, 7 different isoforms of vitamin K. So a lot of times when people, particularly people who are on blood thinners, they know vitamin K is like a buzzword because vitamin K is involved in clotting. So they say, oh boy, I'm supposed to avoid vitamin K, but that's a different form of vitamin K. Vitamin K2 is mostly responsible for calcium shuttling. So it can help to, this simplest way to describe it, it can help to direct calcium where it needs to go and away from places it shouldn't be. Like, for example, into bones, away from tendons, into bones, away from arteries. And so that's one of the reasons we had you take it, is I've noticed that when people experience injuries, one of the natural parts of the healing process is to add some calcium matrix to that injured tissue. The idea there is that the inflammation stimulates this deposition of calcium, and that's essentially like the body's form of spackling. It's trying to fortify the area, lay down some spackling, and your body will deposit some, reabsorb it, deposit, reabsorb it. But for whatever reason, I've noticed that in particular athletes, powerlifters are in that group, they just lay down a lot more calcium. So what you end up with is someone who has a calcified tendon or a calcified muscle. And so sometimes when people tear one of those structures, we'll monitor with the ultrasound. If we see there's too much calcium being laid down, too much of a calcium burden, as we would say, I'll have them take a higher dose of vitamin K2 so they shuttle some of that calcium elsewhere. It seems to work. There's not great literature behind it, but this is one of the spaces in which, the number of studies out there on, world-class powerlifters taking vitamin K2, you're not going to find a study on that.
Yeah.
So you just have to base it on your patient population. But it's something, K2 I'm a big fan of. For the most part, I think people who are taking vitamin D, which I think should be almost everybody, should be taking K2 because, again, vitamin D, along with doing many other things, helps to absorb calcium from the gut. K2 will get it where it needs to go. That's a pretty good general rule.
Let's take a bathroom break real quick, and then we'll come back and talk more about the supplementation and diet. Inertia Health is a premium telehealth platform specializing in hormone optimization and preventative medicine. Are you looking to optimize your health in and out of the gym, improve recovery, sex drive, and quality of life? Have you tried speaking to your health professional about this and have gotten the cold shoulder, stereotyped, or just told as part of getting older? You just go to americahealth.com/table talk, and you can create your own lab, or you can take labs that we've had set up for them, which are based upon the same labs that I've been doing over the last 15 years. Or you can use their guided optimization. With this, they'll put you in touch with a patient care coordinator, which is actually pretty cool because you get to sit down and speak to somebody that can understand what you're looking for from hormone optimization and the preventative medicine standpoint. After that conversation, they'll determine which labs that you should and which tests you should have done. And then from there, get the labs done. They'll review those labs with you and put you in touch with one of their hormone optimization specialists that can determine which supplementation that you should use over the counter or prescription. americahealth.com/table talk. The discount code is table talk. Today's episode is brought to you by First Detachment. Are you looking for a supplement brand that truly understands hardworking athletes? Look no further than First Detachment. 1D's real world experience is what I would consider, and they consider, battle tested. I have known Justin Harris for pretty close to 2 decades. And if there's anybody that I trust with nutritional and supplement needs, it's Justin Harris. If you guys have followed me and have followed the podcast, you pretty much already know how I feel about the supplement industry. For me to get behind any brand, I have to trust the brand and I have to trust the person both. And I'm pretty sure you guys all know why. When it comes to creating formulas and putting products on the market, and there's nobody that I trust more than Justin Harris. While I love all of their products, I'd suggest that you check out the Field Rations and WTH first. Go to www.firstdetachment.com and use the code TABLETALK10 to save 10% off each order. The link is in the description. I want to let you guys know that we just had a limited edition drop on the website last week of new items that sweatshirt, flannel, t-shirts, shorts. Basically, the limited edition items are the items that directly support the Table Talk podcast. So if you go to elitefts.com/limited edition, or actually just the link in the description, you can find the limited edition items that we have now, which there's the one that I like the best is the shit suck good great, which is all emojis. The designs I always like the best, right? They're the ones that don't sell for shit, but they're the ones that I want to wear that I like the best. And there's the cigar one as well. And they're all there on the screen for you guys to be able to see. So if you go to elitefts.com/limited edition, the other thing that directly helps support the podcast that I haven't talked that much about is the Table Talk crew. The Table Talk crew is extra edition episodes that go out once a month. The content of those episodes are AMA related, question related, that come from the Table Talk Discord group, which is also part of being in the crew. When you're in the crew, there's dozens of ebooks that are in there. There's every seminar that we've ever done is put on there. There's courses that are put on there. There's series that have put on there. The original YouTube channel that we had for many years before we migrated to the newer one, all that old content is on there. There's discussion groups for just general training, fitness, life, nutrition, basically everything that you can think of is on. So just go look at what that is, or better than that, just go to the description, click on join the crew. That helps directly support the podcast, which is how we're able to keep this thing rolling. All right, we were talking about supplements, and I want to stay on that one. But before we keep going down this path, let's reiterate the importance of having a solid and firm understanding of a basic diet first.
Yeah. Even from the basic fundamental, at the most fundamental level of just calories, forget macronutrients, forget micronutrients. They've shown that if there's even like a 15% deficit relative to what you should be intaking, we could talk about, what that could be, but that can even have profound effects on your tendons and predispose you to tendon tears. So if you're at a calorie deficit, so just getting enough calories is critically important, which I often have to talk to my athletes about. I run into this a lot with wrestlers who are cutting weight and they end up tearing stuff. So getting enough calories is number one. And then you got to get enough protein. I mean, the meatheads are going to know that already, but there, I guess something worth mentioning here that I found interesting. I always like to think through these things, and of course, whey protein is very popular. Branched chain amino acids. The reason being is the whey protein is high in branched chains: leucine, isoleucine, valine. Leucine is like the key regulator for muscle growth, right? It turns on the switch for mTOR, for muscle growth. And so lots of those type of proteins are good for the muscles. But those same types of proteins, chicken breast and, ground beef, they're not particularly high in glycine, in proline, which the tendons need. So if you think about it, it makes perfect sense. We're eating the muscle of a chicken or, of a cow. That's going to become our muscle. But we no longer really eat the connective tissue. We're not chewing on the bones. We're not eating the tendons. So we don't really get as much of that in our diets. And there's some thought that we used to get a lot more in the days of hunters and gatherers. We were doing those things. We were chewing on bones and eating the whole animal. Serrano will talk about this sometimes. He'll say that, there are only like 3 animals that eat only the muscle. It's like vultures, maggots, and us. So we're in good company, But so there's some importance to eating the entirety of the animal, or at least consuming hydrolyzed collagen, so you get some of those other amino acids that are critical for connective tissue. Because in collagen, it's a triple amino acid repeat. In other words, every third amino acid is glycine. So there is a ton of glycine in collagen. And if you don't have enough glycine in your diet, you're not going to do particularly well. And now people can follow whatever type of diet they want. I don't care. But I will tell you, my patients who are vegans, I have noticed that a lot of them have weird and significant soft tissue injuries. They're tearing all kinds of tendons. We also have an aesthetics division in our practice that my wife runs, and we find that their skin isn't so great. They kind of get premature aging of the skin. Now, this is an observation, but I've wondered whether that's due to an absence or a relative deficiency of things like glycine in the diet, because they're not eating animal products. Their plants don't have a whole lot of this stuff. So if they're entirely avoidant of those, maybe that's a problem. So you got to get the protein, and particularly the key amino acids for the connective tissue. I mentioned that copper is essential. There's an enzyme that's responsible for doing some of that cross-linking. Without sufficient copper, that enzyme can't function. Again, fortunately, most of us get enough copper. In fact, some of us get too much copper relative to zinc. That's kind of a whole different discussion, but copper is important. Vitamin C, we mentioned that. Some other nutrients that have been found to be beneficial for connective tissue health: vitamin D, turmeric or curcumin, which I am a fan of, and fish oil. So those are kind of general health supplements, but they're equally helpful for connective tissue and tendons.
Where would wobazine fall in there?
Say it again.
Wobazine.
Oh yeah, I mean that's a great one for. It's an enzyme product. It helps to break down a lot of the molecules that are formed during injury that lead to persistent issue and inflammation can be broken down, eliminated by that product. So all those different types of enzymes can be effective as well. That's kind of more for people will take it if they've got a fresh injury or if they've got just a chronic injury that they're trying to manage. I don't know as many people that take it for preventative purposes.
Yeah. No, that's something that Eric had me take. God, I've been on it forever. Just a little bit. That's 4 or 5.
Yep.
Unless, something gets acute.
Then you kick it up.
Oh yeah. Then it's like, how much should I take? Like 3 handfuls a day.
Right.
It's like insane.
Right.
And, but I never really noticed a difference when it was just it's like 3 or 4 days, just a habit.
Right.
It's just good. But I did when it goes up.
Well, I think there's value to that because I'll ask people, I'm a guy who grew up really kind of like around nutritional supplements. I worked at GNC when I was a teenager and have a nutrition supplement line currently. And I've kind of always been interested in the science of nutrition and nutritional supplements. And so I routinely get questions about joint supplements, and glucosamine and chondroitin, for example, will come up. And the studies pretty much show that the responses are kind of 30-30-30. 30% of people say, no, I didn't do anything. 30% of people, yeah, it kind of worked. And for 30%, it worked as well as like a traditional anti-inflammatory medications in terms of the discomfort that people experience. But the issue is that a lot of these studies that look at things like joint health and musculoskeletal issues, the studies look at the subjective pain, right? That's what people care about. Do I have pain or do I not have pain? But they're starting to think a lot of these products, like the enzyme products, glucosamine, chondroitin, curcumin, that sort of thing, have value in the more long-term time frame because it can help to preserve the health of the joint. So it's going to prevent a problem before there is a problem, or prevent it from getting worse. Because I mentioned before how arthritis, chronic tendon problems, it's sort of like chemical warfare. You've got all these unhealthy chemicals floating around in or around the joint. Well, some of these supplements can help to decrease the levels of those not so healthy molecules, so it helps to preserve the joint and prolong the life of the joint. So it's hard to convince someone to take, less hard for this group, but just the general population. It's hard to convince them to take certain things. Just trust me. It's going to help you in the future. But I think that more and more these are having that effect. And glucosamine, for example, it's my understanding that we used to think, okay, you take this, and the reason you're taking is because the joints, like the cartilage, has this as one of the building blocks, so it's going to go in there and rebuild. But we're finding out a lot of these things work through totally different mechanisms. Like, for example, the gut has these immune areas called Peyer's patches. And the thought is that the glucosamine at the level of the gut has an immune regulatory effect. In other words, it decreases inflammation in the gut, which in effect decreases inflammation in the joints. So, we're finding out a whole lot more about these different supplements. I mean, even medications, metformin, one of the oldest, most used medications, even recently, we've discovered a number of new mechanisms. Oh, we used to think it only did this. Now we're learning it affects the gut microbiome and it does all these other things. So I am an advocate for several of these nutritional supplements for many reasons, but you got to kind of think long game here instead of the immediate, hey, I pop it. Do I feel better 2 hours later?
A couple of thoughts I have on the supplements is most of the people that have been following the podcast know that I think most of them are just bullshit, which is just overhyped. And it is true for the most part. Most are.
Agreed.
But there's also a lot of them that have benefit and things that I've been using for years where it will scale up and down, based upon what's going on at the time. And a lot of them are recommendations from Serrano or yourself. And this is just a habit thing where I always make sure I'm taking something in the morning and something at night. Okay. Even if it's just C, right? Because it's water soluble and it will go through. Because if I ever pull it out to where I get in the habit of not taking anything at night,
it'll just all go away.
Then it's so hard to bring it back again because there were so many years that weren't there. So when it scales down, it's like, okay, now this is just my minimum. Yeah. Zinc, D, C, K, the Wobazine may come out. Yeah. The Armour thyroid, well, that's a medication, but that's in the morning because there's medications that are in there, a couple of them that are in there too. Yeah. And so you build this habit, of that. So then if I do tear something bad and then there's more things I need to throw in than Wobazine or whatever this stuff is, I'm already taking shit.
That's a great point. It's all about habits, right?
100%. So I won't let it come down, but I'll let it come down to what I think that bare minimum is what's bad about taking C a couple times a day?
I like that strategy. I'm going to start recommending that to my patients because that's a great point. I'll try to get them to take one thing. They'll say, I can't remember to do it, or I can't. Yes. I'll say, I'll start with something vitamin C, vitamin D, take it every day, same time. That way they build a habit and we can add or take away. That's a great point. I like that strategy.
Well, what happens if, from the habit forming standpoint, what happens with that patient, say 15 years from now, and then they now have to take blood pressure meds, but they can't remember. Right. Well, that's not good.
Yeah, good point.
So if there's already that habit established, it kind of plays into that whole thing. Yeah. Where
I think that's a good taking some nutrients in the morning and at night. I think that's a good pattern. People, there are some people that they're taking it before and after every meal, going crazy with it. I agree with you that a lot of these things have very limited utility. I'm most interested in things that actually have literature that supports their use. It's a short list. But to your other point, if you're dealing with a particular condition, that list grows longer. You take it until that condition is resolved, then you go back down to your baseline core supplements. But I think getting something and getting in the habit of taking something in the morning, the evening, there are enough nutrients you can put into those two categories that's going to serve you well in the future.
Now getting to, you tapped on it a little bit with metformin, where on the meathead side, there's always good and bad with how things evolve, where, Merck Health, I think, is amazing because they're doing the blood work or they're helping people with hormone optimization and just a next level. Link is in this description, guys. There's a discount code, but this is how good I am with the promotions and stuff like that. Because I don't want it to disrupt the conversation because it's very valuable in what they do. But sometimes when other people won't use somebody like Merrick or see a primary care physician, but they're just going to try to mitigate side effects of anabolics or whatever they're doing on their own. So then they're throwing in other meds on top of these meds and say it is metformin and now it's impacting gut biome, but they don't know it's impacting gut biome. Or it could be bystolic or blood pressure medication. Like, what could that potentially be disrupting? Because some of these things could play into injury and injury rehab, i.e. like a blood thinner, creating way more, making something look way more tragic than what it could potentially be. What are some of those things that you've seen?
The medications that can have adverse effects for athletes and that sort of thing.
Not that they should go off. I mean, that's a conversation with their doctor.
Sure. Well, it's a good point that you should be very thoughtful about the medication. you would hope that the provider would be thoughtful about the patient's lifestyle. You know, if I've got a powerlifter walking into my office versus just a 75-year-old who never gets off the couch, those are very different lifestyles that I need to consider when prescribing medications. And so if you even consider blood pressure management, for example, beta blockers are often used. You want to be cautious about which athletes you give those to, because it slows everything down. So if you give an athlete a beta blocker, they're not going to be able to reach maximum peak performance because their heart rate's not going to get quite as high, and they're going to feel that early fatigue. So you have to be careful with those medications that affect the cardiorespiratory system. To your point, a non-medication, anything that thins the blood, while that's generally a good thing to do, is to have something like fish oil that naturally is a little bit of a blood thinner. If you tear a muscle, you're going to hemorrhage all over the place. Now, it's not necessarily a problem, but it can cause issues that you want to be aware of, where you can have even a tiny tear and you have a huge response. You're like, I think I got a big problem here, when in fact it's just related to the fish oil you're taking. Other things that come to mind, diuretics, people have got to be very careful with. We talked about how if you're not properly hydrated, you can tear stuff. But beyond that, if you're too dehydrated, you start getting into kidney problems and all the rest. Other things that I can think of, there are a lot of medications that really mess up the gut microbiome. And then we're learning that's more and more important for so many different functions. And I'll tell you, it's actually less of a problem. I'm finding there's less of a problem for this population because they're generally they're kind of medication averse a lot of times. Whereas the traditional, Western patient is on a list of 10 meds. And these people come in and they're, I think the average is around 10 meds if you're age, 65. And there are certainly interactions. There are certainly side effects that aren't being recognized. There are certainly issues. So you want to be really mindful to consider before going on a medication, to do your research, and then to always revisit and iterate on medication regimens. And okay, am I on the right thing? Is it time to go off? You mentioned before, you had asked around, okay, do I still need to take this medication? Important to do, because to your comment about habits, people can be on a medication, stay on for 20 years. Hey, you didn't need that, for the past 15. So, very, very cautious with medications. Okay.
With the, my brain just died.
Well,
go ahead.
I was going to say, Dave, that, the other important point there, I guess, is that people think that, supplements are over here. They're very innocuous and medications are over here. But a lot of supplements can have pharmaceutical level effects, and the other way around too. I mean, medications, sometimes they're kind of mild in their effects. So it's weird to me. There's this clear distinction between nutraceuticals and pharmaceuticals, when really, you have some doctors say no supplements work, period. Like, okay, you want to look at this stack on creatine that's this high. You want to look at the stack on whey protein and vitamin D, come on. So you want to be equally kind of cautious and thoughtful about supplements and medications.
I believe so, because I've had some very interesting conversations in regards to fish oils and blood thinners, and aspirins. And, when I was on blood thinners for a while, it was, my question would be, well, can I just take fish oils? Well, no, you can't control the quality of all that, right? And I understand. I get where all they're coming from there. But then, later on, when it comes out, it's recommended that I take baby aspirin or fish oil. So I'm like, no, wait.
Well, a lot of this, Dave, frankly, is cover your ass medicine, CYA, where, there are studies that show if you have atrial fibrillation, you should be on maybe this medication. Here's why, here's for how long, et cetera. There's really no study that shows, how much fish oil could be comparable and is it as effective. So, the doctor's trying to say, I don't know, though they might not want to admit their ignorance. So they're just saying, no, don't do that, do this. And unfortunately, there aren't ever going to be those studies in a lot of cases on certain supplements and peptides, or whatever the case might be. And that leaves us a little bit at a loss in terms of being able to recommend things.
Well, going into the peptides, we talked about that a little bit off air. What are your opinions there?
Yeah, it's interesting. Peptides just being a sequence of amino acids like insulin, like growth hormone, those are all peptide hormones. They're not, some magic new class of molecules. Though there are a number that have come out in recent times because you have these labs that are able to synthesize various sequences of amino acids that are supposed to do different things. And there are clinics out there prescribing all kinds of different peptides for all kinds of different purposes, compounding pharmacies making peptides, as well as non-pharmacy businesses making peptides. And there are some that I think there's no question that some of them have an effect, whether we're talking about growth hormone analogs or whether we're talking about some of these that are supposed to enhance tissue health, but we just don't know what all of those effects are. So this is kind of this gray zone where some clinics, because peptides are really popular, hey, whichever ones you want, I got them. I don't prescribe them in my clinic. The reason for that is because since they're not FDA approved at all, if someone is taking a peptide at my recommendation and they get a blood clot or something, even if it's not related to the peptide, they say, oh, that was the peptide that caused that. And I'm kind of hosed. Oh, yeah. So from a medical protective standpoint, I don't prescribe them. There are a lot of providers that are more kind of cowboy than me, but from an efficacy standpoint, I do think some of these are beneficial. Now, we were briefly talking about BPC 157, which is most commonly, that's the one I hear probably most often about in my clinic because it's supposed to enhance soft tissue healing. So they did some studies where they transected rat Achilles tendons and found that when they were treated with BPC 157, they healed better and faster. Well, we're not rats, so you can only do so much with that data, and there just aren't the human studies. So all this is anecdotal, but thousands of people are taking it and say, hey, it really works. This is a natural compound. It's part of gastric secretions. I have some people who swear by it. I have other people say it did nothing. And so it really stinks because I wish that we had the studies, number one. Number two, I wish that we had a reliable source where it's not these companies making these research peptides. We don't know what's really in them. And I wish that we could more confidently recommend them. So without going too deep into the different peptides and mechanisms and all that sort of thing, there are a number. Some of them definitely do things. A lot of them I'm less comfortable than some people with because I think that if you really dive into the mechanisms on some of them, they're doing things that are going to lead to other issues down the road that people don't readily appreciate. So it's a little bit of a mixed bag on peptides. What has been your experience with the interest amongst people?
Well, the interest is through the roof. Where as I was saying off air, I've always been one of these guys that, I just jokingly say, so they weren't good enough to be drugs in the first place. I'd rather just find the growth hormone if I'm going to go that route.
Instead of the growth hormone.
And know that it's real and know that it's not fake or whatever this other stuff is. And the one that you spoke of, I did try and it did nothing for me, but I'm an outlier, as far as the accumulated damage that I have. I'm a different case. I get that, and so that makes a lot of these things really hard for me to digest when I'll have people say, I'm just trying to think of an example of whatever's trending right now for joint health or whatever it is. And be like, man, I took this and it's the greatest shit ever. After 2 weeks, I feel like a new person. And I'm thinking, how fucked up are you really? Yeah. Because you're never going to feel like a new person. Right. I mean, if it's really, I would say you're hurt, injured, and fucked up. Yeah. And you get to this level where, there's essentially permanent damage. That's a lifestyle change and maybe a little bit of identity, but it's a lifestyle change that you either manage positive, negatively, or neutrally. And, there's some things that can help mitigate it, but there's nothing that's going to help cure it.
Yeah.
It's too trashed for that. Yeah. And even a hip being replaced, I can't say that cured the hip. Right. It's a prosthetic. Right. It's a different thing. And so those all seem to fall there. And then I'll have, I healed faster. Yeah. And I was like, how generic of a term is that in the first place? Yeah. Like I've had some injuries that a week later, I was just fine. Other ones that didn't seem like a big deal. 4 months later, I'm like, so what's faster mean?
So how quickly would you have healed without? You probably don't know, right?
Yeah. I mean, well, how would you know?
Right.
Because there's no defined basis. And I know you've been asked this, like strain tricep. I mean, how long is this one going to take?
Day.
And you're like,
yeah, right. Every day. Yeah.
Yeah. And it took me a long time. I mean, it sucks because it took me a long time to realize there really is no answer for that.
Highly variable.
It's just how much better can it be each day to each day? Right. That's what we have control over.
Right.
And so I don't buy it healed 3 weeks faster because I'm comparing it to my buddy who had the same thing.
Right. That's a great point. That's a great point. Yeah. Again, I don't care what people do. In fact, it's, all the self-experimentation people do, I learned from, but it's tough. We were talking about this earlier. As a physician recommending things there, I just have to be careful with certain things that don't have approval. That's just the bottom line. So, if people want to try it, I'm interested in hearing their feedback. And so I think we're going to be hearing more about it because peptides continue to come out to be developed. We're just in this real conundrum where certain studies aren't going to be done either because it's a natural compound. It can't be patented. There's just no money behind it for pharmaceutical companies to get involved. So you're not going to have these large randomized double-blind placebo-controlled trials. So you're going to be left in this space of, well, it did this in a rat, so maybe it'll do it in me, which, by the way, is one of the problems with tendon research and why it's so lacking relative to muscle research, because most of the tendon research is in like rats and rabbits. And the reason for that is because if we want to study your muscle, we can take a punch biopsy of the muscle. It's going to be fine. It heals fairly quickly, and you're no worse for the wear. We can't just take a chunk of your tendon. That's going to cause a problem. So because of that, we don't have many great studies where we can study the architecture of tendons and that sort of thing in like living individuals. So we have to look at rats and rabbits, and they heal faster. Those structures heal faster in those species, in those animals. So we can't take that data and say, because it happened in a rat, it's going to happen in me. So we have to be careful with the interpretation.
How do you keep up with the studies, but on the other side, I think we're hitting this age of pharmaceuticals that shit's going to change rapidly, fast. And I'm not going to make this a big vaccine thing so forget about the vaccine, but the mRNA technology is some pretty fucking amazing technology. If you go back 5 years, look pre-vaccine, is some of the shit that's going on with that. So now as a doctor, you got to pay attention to that because I think you'll know better than me, the pharmaceutical world is going to change immensely very soon. Agreed. And so a lot of the things that we may be talking about may actually become things of the past, but that's just going to create new things in the future. Yeah. So how do you manage that? Well,
it's challenging to keep up with. And what you have to be cautious about as a provider, as a physician, is to, there are a lot of exciting discoveries. For example, we were talking stem cells earlier. We know that you can take a skin cell and you can turn it. I recently made a post about this. You can turn it into a heart cell. It's something called reverse totipotency. You can take a skin cell, treat it with several different compounds, reverse engineer it, make it go like backwards, turn into a totipotent stem cell, which means it can become anything you want it to become. So you can then create brain cells or heart cells. So this gets around some of the ethical issues of using embryologic stem cells, because no one's got a problem donating a skin cell. Yeah. So you can research is super exciting, but you have to be cautious as a provider to not that doesn't translate to the clinic anytime soon. Yeah. We don't know how to control these things. I'm not going to take a skin cell, do this process, and then it turns into an eyeball in your forearm. So there are a lot of new exciting things, but then to translate that to clinical practice, you have to be measured in your approach. You do have to keep up the literature because, medicine is evolving faster than ever. So that's a continual challenge and something that we're committed to. Again, comes back to having kind of a cutting edge private practice. You want to stay on top of these things because people expect you to, whereas in a larger practice, you can just kind of, fall in line with what's been done for decades. So it's something we try to do. Now, I will say, related to mRNA technology and that sort of thing, I'm less up on that because I focus more of my interests are in like biomatrices and biologics. Like, can we create a new tendon where, or can we create a new joint out of the natural tissue instead of replacing it with hardware, that sort of thing. So
that's still because if you can manipulate skin, can you reverse aging of the skin? Right. So
so we're a little ways off, but it's super interesting. And I less keep up with some of the vaccine stuff or the different technologies in that realm, because it doesn't mean much to me until it's further down the road. Yeah. But I just use that as the example of how fast these things are moving. It's the pace is ridiculous. Unbelievable.
But you make a really good point, which falls back on something that I say all the time. You can only control what you can control.
Right.
And you got to take care of yourself first, then your family, then your business, then worry about all the other stuff.
Yeah. And control focus on the basics too, because I have a buddy who is always asking about, what do you think about this new technology or the float tanks and all this sort of sensory deprivation? And maybe that can do this for the system. But at the same time, he's the guy who smokes, eats terribly. And it's like, okay, let's address the basics before you start thinking about this other crazy stuff.
No, that's a really good point, right? Because ice plunges and there's a whole lot of things that are all trending right now.
Yeah.
Where if all the other ducks are in a row,
yep.
Then it makes sense.
You get that marginal benefit.
Yeah. But if you wake up in the morning and get morning sun on your face, and with your eyes and all the other kind of stuff. But if you're out smoking a cigarette while you're doing it.
Right.
Is it still good?
Kind of negates the benefit.
Or is it neutral? Does it negate the cigarette? How does that work?
Right. Yeah. I mean, it's all about balance, right? But it's so important to focus on those things. And I think that's just it. Is we get bored with eat well, sleep well sort of thing. We want the newest, sexiest thing. But the bottom line is the people who live the longest are the healthiest, are the people who are doing the diet, stress reduction, good relationships. I mean, that's really the fundamental rudiments of a good, healthy life.
Now, as a founder and the owner of your own business and married, and volunteer work. Mm-hmm. That's a lot, so we can speak about balance, right? And we can talk about it. We can promote it. And it's a whole nother thing to do it.
I like how you put up there in terms of the different potential sources of stress, business and being married. Those are probably equal.
Well, they're both big responsibilities, right? I mean, they're complementary, but they're still responsibilities nonetheless.
Sure.
Especially if you're prioritizing things right, because that should fall above, what the business is, but sometimes it doesn't. Sure. There's a shuffling of all this. What strategies have you found to be able to still take care of all the things you need to take care of?
This is something, Dave, that I've really struggled with, and I'll be really interested to hear your input too, because I am spread thin at times, and I'm not the greatest at juggling all of it equally. And on occasion, that had and does get to me and cause problems. And so, I'm not going to give you an answer that, well, what I do is wake up at, 4:30 and then I write these 3 things in a journal and then I do this. I have some strategies like that, some daily habits that definitely help me, but from a maybe more silly sounding, but overarching perspective or view, I think about, when I'm 80, the stuff I worry about on a daily basis just ain't going to matter, that I can't make everybody happy, despite how much I might try. That, when I first got into practice, I'm like, everybody's going to love me because I've got everybody's best interest in mind. I really want to help them. Then I realized, there's some people in the world that are kind of crazy and they're just going to not like you no matter what. And to just put it into perspective, and, again, it might sound silly, but I'll probably be dead soon. The time on this earth is short.
Yeah, it is.
And so, I think back that it's been, 8 years that I've had my practice, and it seems like just yesterday I graduated residency. You just can't allow for the imbalance that life presents at times to get you down. You have to be able to take a step back and say, okay, every challenge I've encountered to this point, I obviously made it through because I'm here. So I'll make it through this next challenge, and maintaining that perspective, I think, has been the most helpful for me. Now, it doesn't mean I'm great at, again, juggling everything every day, but it helps me to take a step back and not be consumed by any one thing. What have you found has been the best way to navigate it?
First off, I found there is no balance.
Yeah.
Right. I mean, you're
a good point.
you're gonna lean into. I mean, just to try to even find that is a stressor in itself.
That's a good point.
Right. So it really comes down to knowing what you can control and what you can't.
Yeah.
And I've said this 100 times on the podcast before, and I'll just keep reiterating it. If I keep my priorities straight, and I've not always done this, and nobody ever does this, where if I focus on myself first, which isn't selfish if you follow where I go here, and I make sure that my physical, spiritual, and mental health is good. I'm not saying great, but good. Then that allows me to take care of my family.
Great point.
Right, because if those three are not where they're supposed to be, then I can't take care of my family, which is the most important.
Yeah.
All right. And then after that would be my business.
Yeah.
So if those first three aren't good,
yeah.
and I've had health issues to where that wasn't good.
Yeah.
And you still have to take care of the family and the business, but it's way harder.
Yeah.
It's a lot harder.
Yeah.
So if I can keep it good,
yeah.
Actually, probably I've learned this more so because there's been times where it wasn't good.
Yeah.
Then you're stuck in a hospital for a month or whatever it is, and you're trying to manage all that. That's really stressful.
Yeah.
So let's not do that again.
Yeah.
Let's keep that good. And then once I take care of that, then I take care of the family, then I take care of the business, then what's left?
Yeah.
All right. Now, whatever's left, I have a choice on. Where I want to put that time. Some of that can be continued education. So with what's left there, I've become very diligent on what I do with that time, where I can scroll through social media and pretend and say that I'm just keeping up with my industry. And maybe I am, maybe I'm not, right? Most of the time I'm not, right? So it's what actually am I looking at? So with that, it's like, what is the intent of me going here?
Yeah.
Right? DMs, make a post, it's marketing, right? So DMs, posts, networking.
Yeah.
Outside of that, how much of that is a time suck?
Yeah.
Compared to maybe it could be YouTube. Then if I'm on YouTube, what am I watching here? Right. It's now I'm trying to build my interview skills, and that. So if I'm watching some stupid podcast with some guy talking to 9 college girls about body counts and shit like that, which I fall down those rabbit holes too. But it doesn't take me very long, because after like a half hour or 40 minutes, it's really bad. I ask myself, is this worth me not learning how to become better skilled at being a podcaster?
Yeah.
And the answer is always no. Like, okay, I need to, because that's not a whole lot of time. So when you get that,
instead of ping-ponging around, you're more intentional about why am I here? Why am I there?
Yeah.
Do you, one of the things, the traps that all fall into, and I think this is partially my personality, but also the career path I took, in my early 20s, my friends were graduating college, getting married, settling down. Now I've got my career. I was just getting started, in medicine. You got 4 years of undergrad, 4 years of medical school, 4 years of residency. You're in your 30s before you even get a job, a real job. And so there's always that, when this happens, then that. When I pass this test, life will be good. When I get into residency, life will be good. But then you realize you never reach that point where you're satisfied, you're satiated, and it is continued by then building a business, because there's always more to be done. I mean, that's a 24/7, 365 thing. You could always be doing something. So do you struggle with that, like constant pull to like, I should always be, or have you kind of reached this point of acceptance where, hey, I'm going to do what I'm going to do and just be content with the process?
No, I'm never content. I mean, it's always that drive, for this. And there is a stress behind that drive. and it never goes away because and the way that I look at business is a little bit different. I don't want to go out of business. Yeah. So yes, I want to grow the business, but my number one goal is to not go out of business. Yeah. So what's the exit plan? The exit plan is to never have to have an exit plan, and I've just accepted that's kind of what that is. Yeah. And so that alleviates that part with that. Yeah. Where over the last, I'd say probably the last year, because what we don't do is to stop and look at what you've achieved. Mm-hmm. Right. And you don't, because there's still so much more. Like you're still not even close to where you want to be. Right. Right. Sometimes you forget how far you've come. Right. And with that, I've started to build in triggers. How do you mean? Well, if somebody that I've known for, like Murph was out here, friend of mine that I've known for 20 years, for the last podcast. And towards the end, he started, talking about what the company was like, 10, 15, whatever it was, so many years ago. To me, in my head, I've now built that as a trigger. So then after I'm done speaking with him, I'm going to take some time and reflect on what it was like 15 years ago. Yeah. Where I was 15 years ago. Yeah. And that helps. Okay. Because normally we don't. Because it's so forward driven. Like, who the hell wants to look backwards? You can't go back. I don't want to go back. No time either. But if you don't take time to reflect, then I think you don't take time to be grateful for what you have. Great point. Because it's, moving forward, the process of moving forward is nothing more than going from one adversity to another one. Mm-hmm. But there are little gaps in between them. Mm-hmm. That's when we need to pause and realize, holy shit, it's actually pretty good right now. Yeah. Now, some shit's coming. That's true. You do know it's coming, but why? I'm still working on this one, but why look for it? Yeah. It's coming no matter what. Yeah. Why not just enjoy that? This is really nice that it's not really fucked up right now. Yeah. Yeah. This is actually kind of cool. Yeah. And I, even my team knows that I love this quote, and I think it's a Socrates quote. You could basically attribute anything to Socrates. People believe it, but it's, nothing is either good or bad, but thinking makes it so. And I think about that a lot. People are like, it's such a crappy day. It's raining. And what's crappy about it? You're just imagining that, the rain's necessary for all the stuff, the flowers and the greenery that you love. And I think any situation can be viewed through that lens. And so, to your point, I have to remind myself of that routinely, that, whether it's going well or whether I'm experiencing challenges, I try to be more kind of in the middle with it, that, hey, it just is. And let's continue the journey. Well, a lot of things really are just right? Because if you look back to things how long have you had the business? That's 6-7 years. 6-7 years. So if you look back to some of the things that were really frustrating 5 years ago. Yeah. And to the things you have to deal with today, you're like, really? Yeah, that's true. But part of that, though, it doesn't mean that you weren't strong enough at that time to be able to handle it. It's the fact that you weren't strong enough to handle it then, and you did, and then you became stronger for it. Right. Which what you don't see is in all those other things that were at that same level that you've had to deal with from that time until the time now, that were just kind of blown off as, hey, this is just day to day. Yeah. Where the only things that really frustrate you now are the ones that you haven't seen before. That's true. You gain tools, right? Tools to deal with the situations. Yeah. Let me ask you, I don't know your history in terms of whether, this is kind of a relevant discussion because when I walked in here, I said, this is amazing. And we'll look at all this stuff and look at this amazing company you built. Did you have the tools when you got started? Did you get a business degree? Hell no. Yeah. You just started. No, I had some advantages. My parents owned their own business. My grandparents owned their own business. So I did grow up around dinner tables and did hear conversations about customer service, quality. I would be lying if I didn't say that those things had some impact on me. Just simple things about how never rely on, the government to be able to help a small business. All these little things, looking back now, were significant to be exposed to at a young age because it did help. And so the degree was in exercise science and nutrition. And then, working as a trainer for a while, and then, getting started in the online retail. It was bootstrapped.
Yeah.
I didn't get paid I paid myself nothing for 6 or 7 years.
Yeah.
And meanwhile, just doing 3 things at one time to be able to cover the cost. But at that time, it was no big deal, because when I was in college, I was working 3 or 4 jobs to pay for college. So what was the difference? But now I'm competing as a power lifter, and I got to do this to be able to pay for being a power lifter, but yet I got to do this too.
Yeah.
And being ignorant, I don't know if that's the word, seeing myself as not smart enough to always have to learn more was an asset. Where when I was younger and people would, say this against me because of being in learning disability classes and all that other stuff, it was a liability. But as I've gotten older, it's like, yeah, I am too stupid. I have to learn more about this. Or I am too stupid. I need to ask somebody that really knows what they're talking about. I've realized it's an asset.
You've leveraged that.
Yes, because now I don't have to be the smartest people. I just have to know people who know more than I do. Or the things that I do learn, I have to read it 4 or 5 times and really master it. And so I'll read a lot and I'll skim read a lot, but then I'll find something that I think is of value. Then I'll read that 8 or 9 times.
Let me ask you, one of the things I really respect about people in this space, like gym goers, and particularly those that are really committed, is that it seems to me, at least it was my experience, that it outfitted me with the skills and the tools necessary to persevere through medical school. Through just kind of like head down, you just wake up, you do stuff, you go back to bed, and before you know it, you're a doctor, that sort of thing. And I think a lot of it came from the gym.
100%.
Did you felt like that too? That pushed you through?
Yeah. The only thing I would say from me personally, the negative quality of all that was the introvertedness and the lack of teamwork.
That's a good point.
That I have this, I got this, fuck you, I'm doing this.
Good point.
Right? That's been a struggle. It still is for me now.
Okay.
To lean into.
Like, get out of my way, I'll do it, I'll make it happen.
Yeah, and you can't do that when you have a business.
Good point.
You have to rely on other people to do what they do.
Yeah.
And be able to take, the pulse off a little bit. But that you don't see with in the weight room, it's all on you.
Yeah.
Right. So I think there's way more good that comes out of it.
Yeah.
Because even in business, it's still on you. Yeah. It doesn't matter what happens, or if it was an employee that did this or a customer that, whatever it is, you own the place. It's on you.
Right.
You could have let the employee go, but you didn't. But so yet this problem came.
Right.
So it always falls back on you. So that personal accountability, I think, far outweighs the other side.
Yeah.
The important thing is to figure out what negatives are on that other side.
Yeah.
And if it needs to be balanced or not. Like, I can have a lot of injuries in my body. Like, I got a lot of damage in my body, but I can't possibly correct all of them. Right. But I can focus on the ones that I need to use the most. Yeah. Where I think what a lot of times people will do in business is they're trying to correct all of them.
That's a good point. That's a really good point.
Well, you have it. I mean, if you look at all the accumulated injuries, like, where do you start?
Right.
Like, well, you have to diagnose. Here's the problem right now. You can't move this.
Triage the biggest issue.
Yeah.
Because the list is long, right?
Yeah. And if you get inundated with that long list, then you're afraid to even triage.
When you talk about, I'm curious about your world of powerlifters in particular, and those that become so committed because you've worked with such amazing athletes. What do you think that it is that drives them the most to keep going? Is it this? Does it become, for those who are the most committed, a true addiction? Is it that it is enhancing other areas of their life to whatever degree? Is it they are striving for some sort of self-identity? What is it? Because it's interesting to me how it can really serve as an asset, as it did in your case, to create this amazing business. I felt like for me it did, but there's that line also where it can become too consuming and a detriment.
I can't speak for everybody, and obviously. I can speak for myself, and I can speak for, some people that I've had to help post powerlifting, because you do something long enough and become identified with it, it does become part of your identity.
Yeah.
Then when that's taken away, there's an identity crisis.
Yeah.
So there's those people there. For some people, it's just the challenge of lifting bigger weights. For some people, it's the challenge of beating other people. Mm-hmm. For others, it's the only thing they've ever been good at.
Okay.
So that can be there. Others, it was introduced to them at a young time in their life that gave them self-esteem, confidence, and things that other things weren't giving them at the time.
Yeah.
So then it became that balancing factor, and it also makes you physically stronger.
Yeah.
So then you're being rewarded with that without knowing it, because people are seeing it.
Right.
Like, hey, you look bigger, and now they're stepping away.
Right.
So in a way, you're slowly gaining power.
Yeah.
Over a period of time.
Yeah.
So there's a lot of reasons why where it can be problematic. And I'm pausing on that because sometimes I don't know if that's a bad thing, because if their main goal is to be the best of all time, then it's obviously going to be problematic, because there's going to be a strong imbalance because of that. Mm-hmm. The problematic part would be when everything else isn't situated to be able to actually allow that to be a full potential. Genetically, they're not inclined to be able to do that, or they're over the hill, for lack of a better word. And a lot of people will get pissed when I say this, but it's a fact, man. Some people just genetically are not going to be able to get there. And then you don't want to create these destructive behaviors, because ultimately the lifter's not the one making the sacrifice. Those around them are. Their wives, their significant others, their parents, or those are the ones that are sacrificing for that person to do that, because they have to deal with their bullshit and all this other crap, because they're in their gym all the time.
So there's a mismatch between the dream and reality.
It is. And that's where it can be unhealthy, but that would be the same with any sport.
Sure.
The problem with strength sports is there's not a day to where you can no longer proceed. Mm-hmm. Like, you're a great college football player, but you don't get drafted. Mm-hmm. Guess what? You're done.
Yeah.
This is a sport that you can just keep, and it's good and it's bad, but at some point it has to become a different thing.
Right.
I try unsuccessfully, but sometimes successfully, for the ones that are, competing at a high level and really, really loving that, to drill in their mind, there is no such thing as the master's division. Like, you're an open lifter, you're striving to be the best lifter you can. So when that no longer becomes the case, say you start slipping, like the Mr. Olympia, when they start slipping in the Olympia, after a while, they're that's their mark. They're done.
Yep.
Just to create a mark.
That's a good point. Where's my end point?
Yeah.
Yeah. Interesting. Yeah. It's something that that's one of the other things taking care of a lot of athletes I struggle with a lot is having that discussion.
Well, it's, the way around that, and this is the way I get around this.
What's that?
Is they'll be the first to tell you that they're all in.
Yeah.
Right?
Yeah.
I mean, they really will. They'll tell you that 1,000%. They're all in to being the best fucking lifter that they can be. And now they're injured.
Yeah.
Right. Now, if they're seriously all in.
Yeah.
Seriously.
Yeah.
And the next nationals isn't, for 9 months away.
Yeah.
They're going to do everything in their ability to be able to become the best they can be in that 9-month period of time. Yeah. Which would mean probably resting a little bit more.
Yeah.
Backing down. There's no need to be actually pushing it 100%
right
now.
Right.
And they know it.
Right.
And you know it.
Yeah.
But if they know it, and then they're going to say that they're all in to being the best that they can be on the platform, they're lying to themselves, because they're not.
Yeah.
They're all into something else.
Yeah.
And that's cool. But they're not really all in. Where the other pushback I'll make on them is a lot of them will just delegate their training to somebody else.
What do you mean?
My coach does this. I have this coach, the online coach or whatever. He does this.
Okay.
And I'm like, so you're all in, but you're not all in enough
to
actually learn what would be the most optimal way to get better.
Yeah.
So you're all in, but you're not all in enough to be able to learn how to optimize your nutrition a little bit better.
Right.
Like you're not all in.
Kind of pulling the curtain back on their mindset.
Yeah. They're only conveniently all in.
Yeah.
They're all in for the things that they want to use or abuse.
Right.
So they're all in for taking tons of tren.
Right.
But they're not all in for staying hydrated all day.
Yeah. Yeah, that's a good point.
So that's the conversation there.
Cause them to realize where their mindset truly lies. I guess just presenting that right in front of them, they then create their own, inevitable endpoint.
Well, yeah, sometimes they don't even realize it. Right. Because they are doing, and not all cases, but in many cases, they are doing a lot of, some things that are jeopardizing their health.
Yeah.
So in their mind, that helps solidify. I'm willing to actually jeopardize my health for this. So I am definitely all in for this. Right. Yeah. So therefore I am. But there's a little disconnect.
Yes.
With that. And once they can see it, then it's like, oh, shit.
Yeah.
Yeah, you're right. Like, actually, this is like, why am I jeopardizing my health?
Right.
But then going too hard right now for something that's here, that's like stupid.
As it relates to health amongst this group, do you find that in other countries where powerlifting is emphasized, or they have these phenomenal teams and coaches, do you feel like, is there more of a focus on overall health here or there, wherever there is, or where is the state of American powerlifting currently?
I think now, as far as overall health, it's probably better than it's ever been.
Okay. Because
they are looking at the bigger landscape.
Okay.
Recovery is a big thing.
Okay.
Where a nutritional, the nutrition, yes and no. It's the effort's there. Let's put it that way. And the only reason I'm saying that is sometimes I don't really understand why a powerlifter would eat like a chicken and rice bodybuilder diet.
Yeah, right.
But the effort's definitely there.
Yeah.
The recovery, like all these other things, they're definitely there, probably more so than ever. But the flip I would put on there is the mental health. Is probably worse because they're comparing themselves to other people that are posting bigger lifts on Instagram.
Okay.
And then that's screwing up their training because now they want to lift a little bit heavier because that's a better post.
A good point.
Than if they were actually periodizing their training a little bit more.
Okay.
So there's always it's weird, right? For whenever you see like a positive in one area, there's always a balance in another area that goes the other direction.
I learned, it was interesting when I heard a lecture that was coordinated with Louis Simmons and helped me out in Russia.
Boris Shiko, yes.
Yeah, Shiko. The difference in how they do programming and how thoughtful they are about certain things versus more Louis' approach. That was new to me. But the fact that they had they brought some of these guys up from the time they were early teens, like, here's what you're going to do over the next 5 years to become. It was so mapped out. That was kind of shocking to me. It's in Russia, maybe a little bit more. It's not like a nationalized sport per se, like Olympic weightlifting would be. Okay. But a lot of the differences are also, in a lot of other countries, they're not going to have access to the same equipment. Yeah. So most of the lifts are going to be more barbell related, oriented type of lifts, pause squats, partials, stuff like that. Yeah. Instead of machine things that we might have access to. Right. So there's always different ways to get to the end. Gotcha. Of what it's in there. We have a farm system here in the States that nobody likes to talk about. We have a farm system when it comes to the NFL. We have a farm system when it comes to baseball. We have a farm system when it comes to, any JC league. Yeah. We have farm systems that come up through. True. We just don't happen to have them for powerlifting and, all these other things. That's a good point.
But we do.
That's a good point. Yeah.
Probably bigger in scope. Yeah. Yeah. I don't know where to go because it's comparing apples to oranges a little bit. Right. I got you. And I don't even know how that works now. Right. Over there. Gotcha. Yeah, it's a fascinating thing. And I've the powerlifters that I do take care of, I really admire because of their commitment to what they do.
but boy, they get some weird injuries.
Oh yeah.
Even different from other weightlifters, be it Olympic lifters or bodybuilders or whatever the case might be. So we're having to get kind of creative with some of the treatment plans.
Well, they're pushing whenever you're pushing the boundaries.
Yeah.
Where what I would be interested to know is, man, it would be cool to see the trajectory of how the injuries have changed over 40 years.
Oh, yeah.
Where when I first came in, it was like knees were a big one. Pec tears were definitely a big one. Pec tears still exist today, but nowhere near like they did before. I would see one or two like every time I competed.
Why is that?
I don't know.
Interesting.
It's interesting. I don't know. I mean, I really don't. I mean, there was a time with gear and bench shirts and all that where I could see that could mitigate, kind of some of that. But even now with Raw being 10 times bigger than, the sport's 10 times bigger than it ever was before, it's not as prevalent.
And why that is.
Biceps they still happen.
Yeah.
But I don't hear about them any more than I heard about them when there was 10 times less lifters.
Okay.
So now adductors, weird shit like that, I'm hearing that I never heard before.
Okay.
And I don't know why. Shoulders seem to be an overuse.
Yeah.
Like every now and again you'll know better than I do, but from the people that I'll see, every now and again you might be a shoulder problem in somebody that's relatively newer.
Yeah.
Usually that's the older people.
Yeah.
It's just overuse, beat up, not taking care of it or whatever it is.
Sure.
I don't know the status of backs. I don't really know that.
I would imagine that's similar to what it was. The weird muscles, the adductors and things, I think a lot of that is because people train so sport specific and then they go and they do like, ultimate frisbee on the weekend or something. I don't know. It's just, that's when I see these people getting injured in those situations, is when they're so sport specific trained. And like we described before, they have very stiff tendons and then they go and do something. I injure myself going down the stairs, carrying groceries, playing ultimate frisbee, not in the gym. So, I don't know if people are just training one way, but then thinking they can be more of a athlete across the board, or what the case might be. But that's what I noticed for those weird injuries.
That's a good point, because Branch Warren was just out here before the Arnold, and he told me, we were talking a little bit about injuries. He said he never got hurt in the gym ever.
Yeah, and he's tore a lot of stuff.
Like stepping off a curb.
Yeah,
maybe it could be debated that it was, the training set the stage for that to happen, but nobody can prove that one way or another.
Right.
But I've seen that be the case with a lot of people.
Right.
I always jokingly say it's always them doing something stupid that they shouldn't have been doing in the first place. Like you haven't played basketball and usually sprinting. Like you haven't sprinted in 5 years, so you decided to race.
Yeah, there's nothing you're doing in the gym that's preparing your body to sprint. Yeah, absolutely. Because there's so much variability in these different injuries, it's so important to be well equipped in terms of addressing all the issues. I mean, we've been talking a lot about, procedures that can be done, or training styles, or even nutrition. But I mean, the hormones, everything you got to have in line, because I can't tell you the number of people who have come in, they've got weird tendon problems, polyarthralgia, or joint pain in multiple locations. I say, we're missing something, and we get blood work done, and they've got all kinds of hormonal issues. That all has a massive impact. I mean, it's not just, it's not hearsay. It's not hand wavy stuff. I mean, it's real science here that hormones have a profound impact on, tendon turnover, on pain, nerve receptor sensitivity, all that sort of thing. So that's what we're really trying to address in my clinic, is like the entirety of that picture. So we can really satisfy those things, because so much of medicine is so segregated, segmental, to where you go to this guy, he's only addressing this one thing. The classic example is someone with prostate cancer might go on androgen deprivation therapy, but that might predispose you to heart problems a little bit earlier, but he didn't care about that. He's focused on your prostate. That's
good point.
Cardiologist problem. So that whole body focus, man, is more and more rare. So we're really trying to hone in on that in our practice and integrate as many experts as we can as we continue to build out so we can address all these people across the board. And it's people in this type of environment, the athletes, the gym goers, who appreciate that. They're like, I want to go somewhere, get it all done. I don't have to go to this guy and this hospital and that hospital. And I think that's really the way of the future for a lot of what patients are demanding.
Well, I think it should, if I'm speaking to them, it should be, that I would almost default to, somebody that practices the way you practice, unless it's like cold flu or some basic shit like that. Right. And then let that be the referral out if it needs to be someplace else. Yeah. And then go into, primary, and then having primary referral, because it's, to God knows who. Yeah, yeah. It's all about being able to dive deep. It's cheaper. This is what I don't think they understand. Yeah. And this is one of the things that drives me crazy when I'll send people, and if it's a private pay, because a lot of the doctors I know now are all private pay. Yeah. And I can't, I don't want to pay, this shit that goes along with that. And it's like, okay, no, just wait, let's walk this through here. Yeah. Yeah. So you're going to go to your primary care. Yeah. Right. And it's going to take you a month to get in there. Right. And so you got a $20 copay. Right. You don't see what's actually being charged to your insurance company, but anyhow, you got to wait a month, and now you had to drive there. It took 3 hours of your time. You had to be able to come back. Then they still couldn't address the issue. So now they're going to send you to the sport medicine person. Yep. And then you're going to go through this whole thing again. Yep. And then by the time anything actually gets even halfway imaged, you're 5 months in. Yeah. Your copay now is up to $160 from the 4 or 5 people that you had to see. Yeah, and maybe you took time off work to go to all these visits. Yeah, and then there's an MRI. It's like, oh my God, you're kidding me. Yeah. You go here, you drop all the money that would have been spent over the 6 months, and then you get the answer right now. Yeah. And then you start your course of, I don't get it. I think patients are starting to become hip to that, where they're like, I'm not going to waste my time with all this stuff, because I'll see somebody who comes in with this, what they thought was plantar fasciitis. We diagnose this Baxter's neuropathy. We see it, we treat it, done. And they're like, man, if I would have gone to primary care, they would have referred me to physical therapy. I would have done that for a while. Physical therapy is extremely valuable, but sometimes it doesn't get you where you need to go, just like anything else. And so, okay, I did that for a couple months, and then I saw the foot doctor, and he put me to boot for a couple months. I spent 4 months. Yes. I still have the problem. So I think people are becoming hip to that. Like, oh, I know that I would have been required to get an x-ray first because my insurance wouldn't approve the MRI otherwise. But now I can just come here and get an ultrasound. So people are becoming hip to it. I think there's going to be more of a demand for it. So when young medical students or residents reach out to me and say, hey, how are you doing what you're doing? What's the model like? I say, hey, if it's attractive to you, do it, because people are going to demand it. I mean, we were very fortunate where when I opened the clinic, I really didn't do much marketing or any marketing, because I start taking care of a couple people at, say, a couple of gyms, and all of a sudden you start seeing every member of that gym when they have a problem, because they know you, they trust you, and they like being able to get in. I know what's going on. I know what all the options are. So I think we're going to see a lot of changes, fortunately, in healthcare in the next 10 years or so. Were there any topics that you wanted to talk about that I didn't bring up? Gosh, the tendon thing I think was important, because I see so many issues there. We touched on regenerative medicine, which I do a lot of. There's nothing that's front of mind for me, but if people have particular questions, they can, reach out to me or otherwise. Dave, we also, just to kind of further describe our clinic a little bit down near Cincinnati, we have a multidisciplinary clinic where we offer many things that are aimed at enhancing tissue health. So whether we're talking about the musculoskeletal system, what I do with the sports medicine side of things, we have an aesthetics division. We have personal training, physical therapy. We're integrating more of just general wellness stuff. So it's a very cool multidisciplinary model. And again, it's really amazing the number of people we get from Columbus, for example, because Columbus is like a mecca for fitness stuff. And so a lot of people within that realm are like, hey, this is the type of place I want to go to.
which is exactly the type of place I would have wanted to go to, which is why we built it the way we did. So, we're here to serve people with whatever questions they might have. Happy to answer those.
Okay. What's the best way people can get a hold of you?
You can email our clinic info@inertiamedical.com. Inertia is INERTIA. We're also on Instagram @Inertia Medical. Our clinic number is 513-570-4464. But happy to. And sometimes, Dave, people call just to ask questions, and while I don't have all day to phone to calls, I'm more than happy to jump on the phone. I have some people call me from Texas. Hey, I got this issue. I heard you on this podcast. I don't know where to go with it. A quick phone call. Here's what I would do. I'm happy to convey whatever knowledge might point people in the right direction. So even if we don't directly care for people, we're trying to disseminate that information. We're trying to connect people, because that's hard to find. You can't often get through to a provider and say, help me, give me some initial, point me in the right direction. So we try to do that for people as well.
The other thing that I would put out there is on your Instagram, you answer questions from people.
Yeah.
Okay, so you answer questions there. Let me just put it that way. I'm not going to tell them to inundate you with DMs and stuff like that. But if they're emailing the questions, and then if you don't get back to them, you can compile these questions. And then when you do one of your Instagram things, then you're actually putting out the answers to the people that people actually have.
Yeah, I mean, you are a model for this. I mean, I'm trying to get better. My personal Instagram is @Dr. Jeremy Girmann, and I'll make videos where I answer questions. But I've realized that's the way to go, because you do this long enough, you see the same questions over and over. People want to, hey, look at this video. They can refer back to it, digest it slowly. So I'm starting to do more and more of that. But this is a great model for people who love what you do and learn a lot.
Yes, because that way it can direct them there. Then it's there. A lot of the questions may have been answered on this podcast, so they can just be directed back to this podcast. Just go back to the beginning, watch from the start, because we covered a lot of different things. I want to thank you for coming out. This was amazing. This was great. And I have the best close ever for the podcast. I just say we're done. Inertia Health is a premium telehealth platform specializing in hormone optimization and preventative medicine. Are you looking to optimize your health in and out of the gym, improve recovery, sex drive, and quality of life? Have you tried speaking to your health professional about this and have gotten the cold shoulder, stereotyped, or just told as part of getting older? You just go to americahealth.com/table talk, and you can create your own lab, or you can take labs that we've had set up for them, which are based upon the same labs that I've been doing over the last 15 years. Or you can use their guided optimization. With this, they'll put you in touch with a patient care coordinator, which is actually pretty cool, because you get to sit down and speak to somebody that can understand what you're looking for from hormone optimization and the preventative medicine standpoint. After that conversation, they'll determine which labs that you should and which tests you should have done. And then from there, get the labs done. They'll review those labs with you and put you in touch with one of their hormone optimization specialists that can determine which supplementation that you should use, over the counter or prescription. americahealth.com/table talk. The discount code is table talk. Today's episode is brought to you by First Detachment. Are you looking for a supplement brand that truly understands hardworking athletes? Look no further than First Detachment. 1D's real world experience is what I would consider, and they consider, battle tested. I have known Justin Harris for pretty close to 2 decades. And if there's anybody that I trust with nutritional and supplement needs, it's Justin Harris. If you guys have followed me and have followed the podcast, you pretty much already know how I feel about the supplement industry. For me to get behind any brand, I have to trust the brand and I have to trust the person both. And I'm pretty sure you guys all know why. When it comes to creating formulas and putting products on the market, and there's nobody that I trust more than Justin Harris. While I love all of their products, I'd suggest that you check out the Field Rations and WTH first. Go to www.firstdetachment.com and use the code TableTalk10 to save 10% off each order. The link is in the description. I want to let you guys know that we just had a limited edition drop on the website last week of new items that sweatshirt, flannel, t-shirts, shorts. Basically, the limited edition items are the items that directly support the Table Talk podcast. So if you go to elitefts.com/limited edition, or actually just the link in the description, you can find the limited edition items that we have now, which there's the one that I like the best is the shit suck good great, which is all emojis. The designs I always like the best, right? They're the ones that don't sell for shit, but they're the ones that I want to wear that I like the best. And there's the cigar one as well. And they're all there on the screen for you guys to be able to see. So if you go to elitefts.com/limited edition, the other thing that directly helps support the podcast that I haven't talked that much about is the Table Talk crew. The Table Talk crew is extra edition episodes that go out once a month. The content of those episodes are AMA related, question related, that come from the Table Talk Discord group, which is also part of being in the crew. When you're in the crew, there's dozens of ebooks that are in there. There's every seminar that we've ever done is put on there. There's courses that are put on there. There's series that are put on there. The original YouTube channel that we had for many years before we migrated to the newer one, all that old content is on there. There's discussion groups for just general training, fitness, life, nutrition, basically everything that you can think of is on. So just go look at what that is, or better than that, just go to the description, click on join the crew. That helps directly support the podcast, which is how we're able to keep this thing rolling.